Maybe we'll start. Yeah. Okay. When we get things back and going, um, I just wanted to say, the next couple of talks are really for people from the consortium. I think it's just Dr. Sayama and Dr. Baird speaking, but the consortium is, now 5 members, and we don't have everyone speaking, but there are several projects going on, and these are the most developed, if I were to say that. Really, this was a vision of, again, of David Frim and Bill to bring, these conditions are relatively rare, and bringing together multiple institutions that sees them, get a critical mass of patients together. And there are other types of institutions, just like Brandon had mentioned, related to Chiari and things, but many of these things aren't. And bringing them together to create a database where it can be used to be analyzed by people in the consortium and even outside if necessary, and really analyze it. And that's really kind of what what I thought about with the AI, in some way being able to analyze it more over time. But again, we have a consortium and we've created a database. Dr. Sayama from Oregon, her interest, I mean, I'd say each individual site has a specific area or topic that they were interested in and wanted to study, and that was the driver of the various things that we're looking at. And Dr. Sayama was interested in tethered cord, and these are all kind of questions that haven't really been answered and need significant numbers of patients. And we're just going to turn it over to her to talk about that in the next part.
Can you guys hear me? Okay, great. Thank you, first of all, to the Hackett family for everything you guys have done to develop this consortium. I think it has, over the years really, come to where it is today. So, and I wouldn't have been able to do this without it. As Dr. Yamini said, I'm going to talk about tethered cord and scoliosis. This is something that I was very interested in and started to look at just at OHSU alone, and then was invited to the consortium and got all these other programs involved to add their data as well. It's not working, so see if this works. Okay, I'm just going to use a mouse. Okay, should it work? I have no disclosures. Okay, so most of you guys probably are familiar with what is tethered cord, but for those of you who aren't, it's the kind that I am really focusing on for this study is what I call the simple tethered cord. But tethered cord just in general is where the spinal cord, the caudal end of the spinal cord is usually limited in motion because it's fixed by something. And as you grow, your spinal column grows, the spinal cord doesn't really. And so symptomatology can come about at any time, during infancy, during, young adult years, or even during adulthood. And it's thought to be symptomatic because of tension on the spinal cord, nerve roots, or possibly from decreased perfusion. So majority of these cases are congenital and related to excess fibroconnective tissue in the phylum. As you see here in this picture, the phylum attaches the end of the conus to the end of the sacrum, so everybody has one. There's thought to be some sort of abnormality during embryonic development. You can get fat in it, it can be thicker, or something that just causes more tension. There are also many other types of tethered cord or spinal dysraphism. Some were mentioned in previous talks where there's open myelin meningoceles. There's other forms of closed spina bifida occulta that this study, we really weren't looking at that. And some of the presenting symptoms and signs, voiding dysfunction, bladder and bowel dysfunction. Some neurologic signs can be sensory changes, weakness, spasticity, gait problems, back pains, and leg pains. Other orthopedic signs could be scoliosis, foot deformities, extremity asymmetries, and then some more kind of atypical signs that we've seen, in infants even. I've seen them where they have lots of pain in their car seat because they're flexed forward, so they're actually more tension on the spinal cord, and they're just miserable in their car seats. And then there's cutaneous signs, such as mangiomas, tuft of hair, pigmentation abnormalities, deviation or abnormalities in the gluteal cleft, lipoma, skin tag, tails. These are outward signs usually indicate, something abnormal underneath. But I think the ones with, that we tend to look at in this study, at least with the kind of tight phylum, don't tend to have these abnormal skin abnormalities. These are more for like lipomyelomyelin and things like that. So tethered cord, just due to the low-lying conus or tight phylum, like I said, is what I was interested in looking at. And so really tethered cord in and of itself is a pretty common diagnosis in neurosurgery. And I think scoliosis is also a pretty common diagnosis, but both of these kind of more narrow picture of just the tight phylum and scoliosis, I think is where this symposium, or not symposium, but the consortium really comes in handy, because it's just, not that common for both of these to happen together. So that's kind of where my clinical question came, because I was seeing a lot of scoliosis patients, and I was noticing that, they really didn't tend to have the typical bowel and bladder symptoms that most of the tethered cord kids presented with. And so I wanted to really define, like, hey, is there a way to figure out, which patients with scoliosis may have some underlying cord tethering, because there have been lots of studies in the past that have shown that if you treat their tethered cord earlier, their scoliosis may not progress. So scoliosis is where you have a lateral curvature of the spine greater than 10 degrees, measured by this Cobb angle example here. There are many different forms of scoliosis. Idiopathic is where we don't know what the cause is, but sometimes there could be an underlying cause. It's divided into age groups, and then congenital is usually where there's a bony congenital abnormality that you can see. So that's obviously slightly different than the idiopathic form. And then there's neuromuscular, which is, any scoliosis that can be secondary to CNS abnormalities or mioneural pathway abnormalities. And these ones often progress. So really what this study was looking at was like the idiopathic forms, where we don't think there's any real diagnosis for why there's scoliosis or what's driving their scoliosis. But in fact, there may be a fair number of these idiopathic kids that actually have tethered cord. So there have been some previous studies, actually not a ton, looking at tethered cord and scoliosis progression. This study by Churn looked at 45 consecutive patients, and they were just treated for tight phylum terminale, so like not any of the complex form of tethered cord. And of their cohort, about a third of them were found to have scoliosis. And so they looked at the Cobb angles before surgery and after surgery, and found that 2 of them improved, 9 of them worsened, 5 stabilized. They did do some statistics showing that if you presented with a Cobb angle greater than 35, you were more likely to progress. And the reason why progression is important is because most neurosurgeons, orthopedic surgeons that treat scoliosis, you will do a big deformity surgery once the curve hits, 50 degrees or so. And so you really, if you could prevent it from progressing earlier, then you may save them from these big fusion surgeries. So they did find a significant number of kids with a tight phylum present with scoliosis, and then recommended that earlier treatment may halt progression of curves. There have been a lot of other previous studies, but they've all looked at all comers with tethered cord, so those with myelomeningocele, lipomyelomeningocele, who I think have a kind of a different etiology of why they progress, because even as everybody has seen these complex spina bifida patients, when you untether them, they're still very tethered, and they're very difficult, dissatisfying surgeries. So as I noted before, most kids present with urinary bowel issues. There was a study by Hoffman et al. Who found that a third of the scoliosis patients also had tethered cord. And as I discussed, I think that there is a subset of scoliosis, idiopathic scoliosis patients that don't tend to have the common symptoms of bowel and bladder. So really we wanted to get this cohort of as many patients as we could through all the consortium sites to determine if there was any clinical risk factors that they presented with that could prompt, in my mind, I was hoping like we could find some risk factors that could prompt earlier imaging, because most orthopedic surgeons don't get MRIs on their kids with idiopathic scoliosis. So this was a multi-institutional retrospective reviews of 4 of the centers involved at the time. It was over a 12-year period from 2010 to 2022. Of those patients, and like I said, even though there's a lot of patients with scoliosis and a lot of patients with like fatty filums and tethered cord, this is a much smaller subset of patients that have both of them simultaneously. So we looked at their clinical presentation, age, sex, radiographic findings, MR findings. Most of them had pre-op and post-op x-rays, but not all of them. And then their post-operative outcomes. There were 79 patients that were identified, which from what I have seen, this is the biggest series so far of just, like I said, this specific subset of patients. About 63% female, mean age was 9 years, average follow-up was almost 2 years. So that's, I think, a pretty good amount of time. And then most common symptoms actually were back and leg pain, where almost 2/3 of the patients had complaints of pain or tight Achilles tendons. And then urine and bowel dysfunction did still occur, but only in about 1/3 of patients. And then looking at postoperative pain in particular, about 62% reported improvements in pain. So, and then looking at the scoliosis on follow-up, a little bit fewer patients because not everyone had the post-op scoliosis x-rays. Our mean pre-op COB was about 30, mean post-op COB was 28.5, so there was a decrease. And using linear regression, we found that the only predictor of post-op COB angle change was a pre-op COB angle. So just to put that into English terms, the smaller the pre-op COB angle, it was more likely to stabilize or improve scoliosis curves. So in conclusion, patients with this quote-unquote idiopathic scoliosis, I think don't always present with the typical bowel and bladder findings. I really want to get this published in an orthopedic journal so that orthopedic surgeons will MR these patients with tight heel cords or with, back or leg pains, even if they're pretty mild. When I took just a brief verbal survey of some of my peds ortho colleagues and asked them, what would make you MR a patient that you're seeing for like scoliosis? And they said atypical curves. So instead of rightward curves, leftward curves, or if they're really young. But otherwise, like I said, do you MR for pain? And they said no. So I think there could be a percentage of patients that if we treat them early enough or find it early enough, that we could actually make a difference in preventing bigger surgery. So yeah, and if you do treat them, then you also may decrease their pain. And that's it. Thank you. Yes, Dr. Daniel.
How would you differentiate this?
I know this is anecdotal, but I do feel like the kids with tethered cord pain, it does tend to be low back pain and not like the upper thoracic, curve pain that we see when curves get really severe. So that's how I've been differentiated it, but
No, I believe you. I just am asking, in those patients with scoliosis, how do we know the scoliosis is due to the tether? Not that you have a tether cord,
don't
all
think we
those
do.
things, but how are you going to differentiate whether it is? Is it that if you're untethering them, a higher percentage will stabilize as opposed to they would stabilize on their own because a certain percentage of scoliosis stabilizes?
Yeah, I don't know that there is any good way to differentiate which ones are going to be which, but in doing both of the surgeries, I would rather do a tethered cord release than a big scoliosis
No, I
surgery.
completely agree with you, and it makes sense. The question really is, does this lead to, is it making the scoliosis worse having a tethered cord? Probably due to an imbalance,
Yeah.
because we always talk about the tethered cord really being the lower segments, not really the thoracic, and leading to an imbalance in muscle strength. So how does that do that? Is it this really the case? I think like every patient with scoliosis who has pain, atypical especially, should have imaging, and it doesn't obviously happen all the time. Just the real question is like, is it just natural that some of the scoliosis will stabilize, or is it improving because of the untether?
Tell me a good way to tell me a good way to differentiate that, and we can look at it. Yes.
The infant with meningocells and tether cord that one operates at the earliest stage, would the adhesions around the nerve root and itself could cause tethering, which would require a secondary operation some years later.
Yeah, I mean, even though this study didn't really look at, meningococles in particular, I think a lot of the kids with, these complex cord tetherings where it's, lipomas or meningococles or whatever have you, you untether them. And I think there's definitely some component of arachnoiditis or something that happens in scarring. So, and then the imaging doesn't help at all for me unless there's a new development of a syrinx in terms of when to reoperate. So I really base it off of clinical symptoms.
In a couple of patients with reoperation, I know that adhesions were so severe that it was even less than what it was with original adhesion, original narrowing or tightening that their cord had.
Yeah, I think there's definitely a subset of patients that I probably made worse by reoperating, and they've had worse scarring. And then I was like, oh, was that the right thing to do? Because I don't know I think there are people that also scar more than others. And how do we differentiate that? And there's been a bunch of things tried to like, hey, can you put a patch in that things aren't going to scar down? Can you, what else can we do to prevent them from rescarring? And if anyone develops something magic, please share it as well. Because I've actually tried on a couple patients like the Gore-Tex patches to see if like on the inner side of my dural closure to see if it would help. And I really stopped after 2 of them because I don't think it made a difference. So, yeah, more. Yes, I think I want to say less than a third of them. With fatty phylums, I don't know that I have seen deterioration. At our institution. I've seen 1 or 2 kids post scoliosis surgery that didn't have pre-op imaging that ended up having tethered cord, and they re-imaged after surgery because of severe pain. So, but that's been twice. And then I have seen a fair number of spina bifida kids like that have deteriorated after a scoli correction. So. These are only tight phylums and fatty phylums and the simple tethering, which most of the studies up to date have looked at all comers for tethering, just because otherwise you don't have the numbers.
And to speak about that, I've had a patient that has had scoliosis surgery and then developed bladder dysfunction and got an MRI and had tethered cord and detethered, and then it got better. So my paradigm is to get pre-op imaging, probably an MRI for every patient that needs scoliosis surgery. And I think as we, evaluate this and investigate that may be an important point, in order to mitigate sort of risk and these, bad things happening.
David Frim, he developed this prone imaging. I don't know. Actually, the radiologists here actually name it Frim prone view for all the kids. They name it that. And any thoughts on that or experience about imaging diagnosis of actual tethering? You know, move the basically the prone, the spinal cord of the conus doesn't move. That's the idea that he had. That when you turn the patient prone in the machine, the conus doesn't fall down to the opposite side. Any thoughts on that or any experience?
I've definitely tried it.
Uh-huh.
I must say multiple times. Usually I'm trying it to prove that, hey, your conus looks like it's moving and the nerve roots look like they're moving, but I don't know how diagnostically accurate it is, only because like there's been, a couple patients at least that their prone imaging looked okay. And clinically they were acting detethered. So I took them back and I found like usually it's a small sensory nerve rootlet or something that's adhered to the suture line itself. And when I've treated them, their symptoms have gotten better. So now I'm not too sure how useful it is, but I still do it because I think if you do notice that it's not moving at all, I think that's helpful.
I don't find it useful, but Frim, like I think that in many things it helps you when you're talking to the family to say that this isn't an issue, but otherwise it's not really. Yeah.
Yes, I think I've tried the True Fist. Hey, you're going to have to teach me how to interpret them because I don't know how to use them. So.
Great. Thank you very much.
Thanks.
So as they're getting ready, we move on to Dr. Baird, who's associate professor at Harvard from Boston Children's Hospital. And Lissa's interest is in brain tumors and specifically related, brain tumors aren't in general thought of as congenital, but it's more somehow acquired, if you like. But there are a group of tumors that Lissa was interested in. And again, these are, uncommon. Each institution doesn't have very many, but potentially the consortium can bring together a larger group of patients, with this condition, and she'll describe it all. But that was her interest, and so this is probably, the next project that has developed in the consortium, looking at congenital brain tumors.
Hello. Well, it's really nice to be back in person, and again, thank you so much for putting this together and the support for this consortium. It's been a really great thing. I think we're learning a lot, and it's great to work with these colleagues and really get some of these very robust data sets together of things that are so uncommon and learn more about them. And this is an example of one of those things. I have no disclosures, but just a little bit of background on why we thought this would be a good topic for a consortium like this. Congenital brain tumors are very rare. They're also very unique. They don't behave or have the same kind of epidemiological patterns as other brain tumors in the pediatric population. And because of those reasons, they're very poorly understood and have been very poorly studied. They also don't really have any clear definition. Some people will describe them as only tumors that are found in prenatal imaging, sometimes during the first few months of life, first year of life, first 3 years of life. We decided to gather data on children within the first 3 years of life just because we wanted to capture everything in the definitions that are out there in the medical literature for what are congenital brain tumors. But some of these tumors may technically not be congenital, just very, very early year tumors. And we'll probably work on trying to tease some of that out and what the appropriate definition should be. Like, is there some stage during the first few years of life where they really start to behave in patterns that are similar to the rest of the childhood population? So these encompass less than 2% of all CNS tumors in kids, wide range of behaviors and outcomes. There really are efforts to improve survival and treatment options in the field of pediatric brain tumors has never really focused on congenital tumors as a subset. And really, I think this population is, of course, the most vulnerable, the most affected by a lot of the therapies available, and new ways of thinking about them are certainly needed. So if you look at the literature and how many patients in the few papers that are out there are looked at, they're very small numbers. There are papers that only have 2 patients. And I think the largest one I've seen now is there's a paper in the 20s. So very low numbers in these individual reports out there. We also probably are seeing these with increased frequency, or because we have improved imaging. We have these great fetal MRIs now that we didn't used to have, and are screening for other things. And so we're probably capturing them more commonly. But we really do need larger numbers to be able to understand them better. Another challenge is that the way these behave is very different than with a similar diagnosis in an older child. They have very variable prognosis. And this is a really good example. A glioblastoma in an older patient, certainly in an adult, is usually a fatal diagnosis. In the very young pediatric population and in infants, it isn't always. And this is an example of that. This is a 3-month-old with a horrible-looking tumor that was a glioblastoma. This patient had surgery, and typically our next line of treatment would be radiation, but you can't give radiation to a neonate. It would destroy their brain. And so they only had surgery. And this patient is 2 years out with clean scans and doing great. And that would be unheard of in an older child. And even though under a microscope, histologically, these tumors look identically, it clearly is not the same tumor. This is another example of the same diagnosis. This was a high-grade glioma. And also, this patient did great. This was day 1 of life when this was diagnosed. And this patient had what's called an ALK alteration, that the molecular genetic pattern of the tumor cells was very unique to what we see in older patients. And they were able to go on a specific targeted inhibitor and also are doing really well. I think that patient is 2 years out. So this is one category that is a very interesting category, these congenital glioblastomas. If you, again, look at them histologically, they're indistinguishable from other glioblastomas we see in neurosurgery, but the biologic differences and the molecular differences are very, very unique. And there's even a report of them spontaneously going away without any treatment at all. Another example of why these tumors can be so challenging, and this is something we more commonly see and what people kind of think of as the malignant tumors in the kind of infant population. This is a terrible tumor. It's called an ATRT, and this is kind of a classic appearance of one. They have this large mass in the 4th ventricle and typically come in with hydrocephalus. They're very aggressive tumors. And this was a patient that was treated with surgery and chemotherapy, and they even went on to have early radiation and then developed epilepsy and had a significant developmental impact. Huge strain on the family. It's just really that the chemo for these tumors is horrific, and this patient survived 2 years. And did we really do this patient and his family any favors by putting them through this 2 years of horrific treatment for a tumor that really did not have a great prognosis at such a young age? And so looking at some of these tumors that are kind of on the other end of the spectrum with survival, I think, and thinking about how aggressively we really should be treating them is important. Similarly, this is a patient with something called a choroid plexus carcinoma, a very malignant tumor, diagnosed at 3 months, very large, had probably been there earlier at birth. And these patients undergo surgery and then chemotherapy. And this patient actually survived. Not all of these patients survived, but has horrible hydrocephalus from all of the scarring from where the tumor was in the ventricles, and has had lots of shunt and hydrocephalus procedures, and has clean scans, no evidence of disease, but is very significantly neurodevelopmentally delayed, and will survive with those neurodevelopmental deficits. So what we wanted to do with this project through the consortium is to really get our institutions together and create the highest volume database we could to really see if we could understand more about these tumors. And we've started with just establishing what the epidemiology is, because that really isn't out there, to see if that epidemiology could give us some insight into other potential therapeutic interventions or things that affect outcomes. We wanted to look at some associated factors, such as any history of fertility treatments, because there's been some anecdotal stories about that patients with in vitro conception possibly have greater risk of congenital tumors. And just generally see if we could identify any genetic or outcome patterns. So we have some early data from kind of our epidemiologic analysis, but there are a lot of things that we still want to look at, and we now have a data set of 323, and that may not sound like a lot of patients for other types of topics, but for this type of topic, it's actually a huge data set. So I think we're excited to have this now and to really dive into it to see what kind of things that we can learn. So this came from our 5 institutions, 323 patients. The mean age at diagnosis was 18 months, but there's a whole spectrum. So the patients that were diagnosed prenatally is the smallest group, the small dark blue sliver, and the ones that were in infancy, and then between 1 and 2 years, and 2 and 3 years, you can see on that pie chart. So we've got a good kind of spread of those tumors at those ages, and then looked at some of their presenting characteristics, their demographics, their family history, and all of these things, and we're really able to get a lot of information about them. Some of the common presenting signs, the majority of these patients presented with hydrocephalus, about 60% of them. A lot of them presented with just growing heads and no other symptoms. A lot of them had ocular abnormalities, and then a handful of other types of presenting symptoms. Kind of see the histological spread here, and I'll talk about that a little bit more. And then looking at conception, we had six patients in this group that had in vitro conception, which is about 2% of the group, which is the same as the general population. About 2% of children in the United States have in vitro conception. So not something that we found to be statistically relevant. If you look at kind of the pathologic diagnostic spread, the majority, not the majority, but the most common diagnosis was low-grade glioma, followed by the neuroembryonal tumors, so ATRT and medulloblastoma, followed by ependymal tumors. All of the low-grade tumors were just about half, high-grade was about a third, and the rest of them were not graded with the pathology reports, and were kind of a smattering of other things. This I thought was interesting, and something I think we should probably look into a little bit more. This is a Kaplan-Meier survival curve looking at survival of the low and high grade tumors as just clustered together. So putting all the low grade diagnoses together, all the high grade diagnoses together. And what we've kind of found, I mean, there's no surprise here that the low grade tumors survive longer, but the survival in the congenital neoplasm population for low grade tumors looks to be a little bit lower than in the general pediatric population as a whole, which is about 90%. And the survival of high grade tumors as a whole looks to be a little bit better. So just kind of an example, even though we're clustering things that are a little bit comparing apples to oranges of how these really are behaving differently in this age range. So just to kind of summarize some of those things, what we've seen so far with some of our epidemiological analysis is that congenital neoplasms are rarely diagnosed in the prenatal stage. The history of conception through IVF does not appear to be increased. The majority of patients present with hydrocephalus, and there's a diverse histopathologic spread that really varies in frequency relative to the entire pediatric population. And then these low-grade neoplasms as a whole seem to carry a poorer prognosis, and that may just be the length of time they have to live with them. I'm not sure why that is, but maybe some things we can look into there. And the high-grade tumors seem to carry a better prognosis, especially the gliomas. Probably, I suspect, not so much the neuroembryonal tumors, but the gliomas that are high grade certainly do carry a better prognosis in this population. Our research teams at all of our institutions did a great job analyzing these data. We're going to present it at the ISPNL conference in a couple of months and have the work accepted there, which is exciting, and then we'll get it published as a paper. So this is kind of, I think, one of the early abstracts we'll get out of this, but there's a lot of things we can really do with this data set, and we're excited to have it. So want to thank the Margaret Hackett Foundation and Margaret for supporting this. It's again really been fun, and I think is very important work. Certainly want to thank all of the research assistants and admin teams that helped us do all of this, and of course our patients. And that's a picture of a patient who was born with neurofibromatosis and just an entire brain and skull riddled with tumors. And I would say maybe 10 years ago, this would have been really an untreatable problem. And we have these new molecular inhibitors now that aren't perfect, but are very effective. And this child had a great response. We started him day one of life, kind of urgently on one of these tumors for reasons that had to do with his eyes. We treated very urgently. And is doing great. I think he's 4 now. And I think we're in a stage in our field where there are new things coming down the pipeline that are we're adding to every year and are improving every year, and we're learning so much more with the better understanding of the genetics of these tumors. And I don't think I mentioned it, but we were able all the patients to get at least some genetic information from the tumors for about 312 of them. So that's a good number of them that we'll kind of dive into next. So happy to take any questions. Yeah.
I have a question for you. I know you're in the pie chart with kids and that little wedge with prenatal,
Mm-hmm.
postnatal. So is it because there are not that many, or because it's not tested as a routine?
I think probably they are not large enough to be captured on ultrasound. It may be that the ones that go to MRI would have captured them, or they're still microscopic. So for instance, there is a type of tumor called medulloblastoma that we now know has what we call a cell of origin in a certain part of the brain, and is almost certainly a congenital tumor, meaning all of those patients are probably born with tumor cells on a microscopic level in a certain part of their cerebellum. And imaging wouldn't pick that up. But that's been something that's recently been discovered, and I suspect is the case for other types of tumors, that they truly have congenital origins, but imaging doesn't always capture them because they're too small. And some may just not be, some may be missed. I mean, I've definitely had had congenital tumors, that we'll go back and look at the maternal ultrasounds, and retrospectively we can see it. Moise. Yeah. No, I think those are the questions we definitely need answered. So, I mean, that we could, it just would require, you know, a tangent. We'd have to look at what tissue is available for these patients. But we now have the cohort that we can pull out and then look into who has tissue available and see. That's certainly something we can look into. Yeah. So I think the answer to that is nobody would ever study that. And the ones that have regressed have happened because they were probably biopsied and then sent for palliation. Biopsied high-grade glioma in a baby, we're not going to touch that. Your child's going to die. They watch him, and then the child thrives, right? So I think that's the situation you get into. Most of the time when these patients present, they're presenting with elevated ICP and symptoms, and you're going to treat them if the family wants them treated. Also, not all of them do well. I mean, some of them do well, which is surprising, but not all of them do well. And certainly some of these will be fatal tumors even in infants. So I think that's a question that I don't know, but it would require sitting on a patient to find out that in a way that nobody's ever probably going to. We've actually started to look at that, and I've had them start pulling that out in different categories. So first 1 month of life, so we kind of know they were born with the tumor, 3 months, 1 year, 2 years, 3 years. So we'll see, but I don't have that data yet. Okay.
All right, we're getting close to the end. I think you know, one of the things we decided with the program was to get new information, new ideas, new minds into the work that we do, and part of that was maybe opening up the forum for further input of information, and with that we devised a grant formation where people would apply for funding to study some congenital CNS related disease. Didn't have to be surgical or anatomical. It could be very basic. And last year we had 2 fantastic proposals that were funded, and They've been working on that for the past year, and for the next short period of time, we're going to have them discuss. Now, this is not my field, so what is the first one is, what is the area? Let me,
Oh, we need
maybe it's better for me to read what the title is. Yeah? Dr. Du's going to talk about one gene encoding two proteins. Yeah, but I'll let you take it away from there. Congratulations, and we
Thank
look
you.
forward to hearing.
I think, yeah. Thank you, Dr. Miyazaki. Good afternoon, everyone. So, first, I want to thank the Margaret Hackett family to support our research. So today, I will talk about the calcium channel and its C-terminal. I have no potential or actual conflict of interest related to this presentation. So first, we will talk about the complexity and the challenges encounters the phenotypic heterogeneity of calcium channel disorder. Then we will recognize the new protein C-terminal of those calcium channel genes. We will see how it's involved in the survival and development from genomic, transcriptomic, and proteomic. Then, based on our research, we will bring out one concept. One mRNA will generate two proteins. What is the voltage-gated calcium channel? Voltage-gated calcium channel is a key transducer of membrane potential changes into the intracellular calcium transients, which initiate a lot of physiological events. So there are 10 members of voltage-gated calcium channel in mammals. They are expressed in different tissues. L-type and T-type expressed in skeletal muscle, cardiac muscle, and neuron. TQ-type expressed in the Purkinje cerebellar Purkinje cell. Okay, the disease-related voltage-gated calcium channel doesn't lack other single mutation disease, which diagnosed to the only same disease. The disease-related VGCC disorder has a very broad spectrum of diagnosis. The phenotype also overlap. We can see the range is from the cardiac symptom to the neurology symptom. During the last decades, the spreading of next generation sequencing technique linked more de novo VGCC virus into an even broader spectrum, many of them related to the development delay and autism. There are a highly correlationship between the disease and the expression tissue. We are asking whether tissue specific will explain this complexity, or there have other factors involved. Okay, well, then we realize a very interesting fact about those 10 voltage-gated calcium channels. All of them have a very long C-terminal in the intracellular. Researchers already found this C-terminal play an important role in controlling of calcium ion permeability. Our group and the other group identified two of them is a transcription factor involved in the neurogenesis. So we can start, I will start the story about beginning our research, then move forward.
So first, let's say alpha-1A subunit and its C terminal. So around 2006, we published the paper. We identified there is a 17.5 kilodalton C terminal of CACNA1 gene, which is present as a stable protein in the nuclear of cerebellar Purkinje cell in human and mouse. After 7 years study, we found the mechanism which controlling alpha-1 ACT expression, because there is a second structure in the CACNA1 mRNA, which is called internal ribosome entry site, which mediated the production of alpha-1 ACT. This mechanism usually is only exists in virus. Alpha-1 ACT, the product alpha-1 ACT is one of several proteins generated by cellular iris. So after we recognize this protein, we are asking what's the function of this protein. So we use a mouse model. We crossed the CACNA1 knockout mice with the humanized CACNA1 exon 14-7 mice. We name this Keiko. So Keiko mice has one non-allele and one humanized CACNA1 gene allele. Very interesting. The alpha-1 ACT expression decreased to the 10% at both mRNA and the protein level. Okay, next let's see the so the Keiko mice have decreased the survival rate to 20%, and also body weight is decreased dramatically. So in this video, with the mice in the middle cannot move is a Keiko mice, and the other is a control, same age, both in P18s. And around 1 month, we also performed the rotorod and open field. Those two tests to test the mice behavior, we confirmed the Keiko mice have impaired motor ability. Okay, to test whether the absence of the alpha-1 ACT is a critical role to cause the low survival rate and low body weight, we crossed our transgenic mice alpha-1 ACT with Keiko mice, only expression alpha-1 ACT in the Purkinje cell of Keiko mice. So we found the survival rate fully recovered, and the body weight also recovered, partially recovered. You can see the third mice we put in is we call it the Keiko alpha-1 ACT mice. The mice cannot move is still the Keiko mice we recognize from previous video. Okay, we also test the rotorod and open field. We found if we specific expression only alpha-1 ACT in Purkinje cell, which can highly improve their behavior. So this tells us alpha-1 ACT play a very crucial role in the neonatal survival and neurodevelopment. Okay, to explore the molecular biology mechanism underlying those phenotypes, we performed the ChIP-seq and RNA-seq. The ChIP-seq identified the alpha-1 ACT occupied the genomic region 300 base pair around the transcription start site, which is a typical transcription factor plays a function area. And this heat map shows directly and indirectly regulated gene by alpha-1 ACT. The bottom one is a Go-term analysis of alpha-1 ACT targeted gene, which shows alpha-1 ACT regulate neurodevelopment and synaptic signaling. So we further verify, because the previous we test the genomic change and the transcription change, we ask whether those changes also proved in protein level. So we test those genes change in the underconfocal and Western blot. We found alpha-1 ACT was able to restore those target genes expression in protein level. Interestingly, the target gene not only expression in the Purkinje soma and Purkinje dendrite, also expression the molecular layer. Okay, so with this finding, we think alpha-1 ACT is essential for the survival and the cerebellum programming in early life. The neurological disorder associated with alpha-1 ACT also have very broad phenotype we mentioned at the beginning. So we think maybe both the mutation located in some region affect the calcium channel signaling, some affect alpha-1 ACT, two different proteins. Okay, because the similarity of the 10 genes, so we applied the research protocol we used in alpha-1 ACT to the rest 9 VGCCs. One of the experiments we did is we insert the stop code at the beginning of the full-length VGCC gene, which will stop the translation of the C-terminal of VGCC, but keep which will stop translation of full-length VGCC, but keep the transcription. Interestingly, we found once we insert the stop code, the full-length gene doesn't expression, but the C-terminal is still there. Confocal image tell us that the stopping the transcription of stop the translation of full-length expression only make the membrane expression disappeared, but the cyto and nuclear expression still there. Okay, this is a transcriptome profile of CCT, ACT, and HCT. We performed the RNA-seq analysis on the overexpression those 3 C-terminal cells. We found a very interesting result is R3 related to the neurogenesis. But when we look deep those target gene, they only have 20% gene is overlapped. So which tell us even they both try to reach the same goal of the neurogenesis, but they through different pathway. Okay, so from this study, we think, based on what we studied, we think the R10 VGC, because the timing, I don't have time to present all of the data, but so far we think the R10 genes have a 2 functional unrelated gene product that may help explain some phenotype related to calcium signaling change or channel function change, some related to the neurodevelopment change. I think we both very familiar this when we take the class in college from the molecular biology textbook. We say we learned 1 gene only generate 1 protein. People think that's the first evidence of the molecular biology. But our finding about the C-terminal of VGCC is an exception of one gene and one protein. One gene, it's possible to generate two proteins. Okay, I want to thank my lab members, my mentors, and our collaborator work with us. Without their dedicated work, we cannot continue our journey in the calcium channel. Thank you. So I would like to take any question you have. It's our basic research, a little bit different from hormone what we heard. Sure.
What do you think the funding from Hackett, how did that help?
Yeah, it's really,
Your,
it's a good
in
question.
your work? I mean,
No money, no work. Yeah, yeah. It's because I get the training from medical school, then I transfer to field to doing the research. The basic research is a little bit different from the clinical research. Is need more dedicated to it and more. I'm not saying the clinical doesn't, but need a lot of tool to verify. Through those basic tool to verify it, then you can try on the human or clinical trial. So it's so this we really appreciate to support our research. Because we began with alpha-1 ACT study, they have 10 different genes. With you guys' support, we started the other different genes, and we found this is the general phenomenon in our VGCC.
thank you.
Yeah. Thank you.
And one other, is there one other person? Yeah. Is this yours? Okay. Dr. Yang is going to present on upregulation of SYNGAP1 expression by redirecting alternate splicing. There will be a test on this stuff. Thanks very much.
Thank
Please
you.
go ahead.
Okay. Good afternoon, everyone. Thank you for the introductions, and I want to thank the Hackett families for all of this, for supporting our study. So I'm a postdoc from John Labs at the University of Chicago in the Department of Human Genetics and the Neuroscience Institute. So today it's my honor and pleasure to share our study of the SYNGAP1 alternative splicing. So first, the disclosures. So a patent application has been filed on behalf of my mentor Xiao Changchang and me, and the Hackett families also supports the studies that contribute to this patent, and I really want to appreciate that. And so today we will talk about the SYNGAP1. So SYNGAP1 is a synaptic protein. It's first identified and characterized in 1998 by two independent groups. So they found that the SYNGAP1 is highly enriched in the postsynaptic density, the PSD, and is overlapping with the PSD95 and is specialized at the excitatory synapses. So thanks to the works from labs of Huckness, Kennedy, Sheng, Grant, Rambau, and others, now we have a more and more clear idea of the SYNGAP1's functions at the synapses. So here is a picture of the spine. So during the normal basal transmissions, the SYNGAP1 indicated by the green protein. So the SYNGAP1 will interact with the scaffold proteins such as the PSD95 and inhibits the red signaling. However, during the activities induce long-term potentiation, the SYNCAP1 will dissociate from the scaffold proteins and release the brake on the RAS signaling, leading to the downstream events, including but not limited to the actins polymerizations and the MPAT receptors insertions into the postsynaptic membrane. And these activities will finally contribute to the spike growth and the synaptic strengthening. And this is what we so-called one kind of the synaptic plasticity, which is important for our learnings and memory. So due to the important function of SYNCAP1 in the synaptic transmission, more and more clinical observations and the genomic analysis have identified the SYNCAP1 as a causal genes for many conditions. For example, the mutations in the SYNCAP1 will cause the epilepsies, intellectual disabilities, autism, eating problems, sleeping problems, and many others conditions. And a recent study also identifies the SYNCAP1 as one of the top risk genes for the autism. So here is a map of the SYNCAP1 genes. It has 18 or 19 exons due to splicing, different splicing. And we can see the mutations can occur across most sequences of this SYNCAP1 gene. And it's interesting that these mutations are heterozygous and loss of function, leading to the haploinsufficiency of SYNCAP1. It means that the mutations will cause the SYNCAP1s to be only one copy to express the protein. And the half proteins is not enough to maintain the normal function. So this brings our question. So since there's still one copy of the SYNCAP1's working properties, we wonder whether we can improve the SYNCAP1 overall functions by regulating the wild-type copies expression. So many studies have shown that alternative splicing can regulate the gene expressions precisely. So including or skipping certain actions will turn the gene expression on or off. For example, here is the mechanism of the nonsense mediated mRNA decay coupled with the alternative splicing. Here in the middle is an immature RNA with two splicing patterns, while the alternative 3-point splice site. So skipping these middle exons can generate productive transcripts, which can be translated into protein. However, including these exons will introduce a premature termination codon, and these kind of transcripts will be degraded by the mechanism of the NMD. So inspired by these discoveries, we hypothesized that maybe we can leverage the mechanism of the NMD exons to regulate the SYNCAP1 expression, especially to increase its expression. So very interestingly, we identify such an NMD exons in the human SYNCAP1 gene. So this NMD exons is between the exon 10 and exons 11 of the SYNCAP1 genes by the alternative 3-point splice site. And we found that this NMD exons inclusions is higher in the neural progenitors than in the human neurons. And this inclusion of NMD exons is decreasing as the neurons are differentiating. So because the NMD exons is dependent on the translation, when we use the translation inhibitors to treat the cells, we will detect more transcripts with the NMD exons inclusion. So we validated these phenomena in the iPS cells and iPS-derived neurons. So here we can see very high level of the NMD exon inclusion after the drug treatment. So the reason we are interested in this NMD exon is that some human mutations can occur around this region. For example, here are two cases. So these cases are diagnosed with severe autism. And these mutations in these SYNCAP1 genes can cause the abnormal splicing of this NMD exon. So in case 2, the mutations will destroy the canonical splice sites, leading to a very high level of the NMD exon inclusion. So this evidence shows that the NMD exon inclusion is an important reason for the disease development. So based on this evidence, we wonder, and we are very interested in the mechanisms for the NMD exons regulation. So here we are very interested in the PTBP proteins. So PTBP 1 and 2 are important splicing regulators, especially during the brain development. They can bind to the pre-mRNAs and then regulate the splicing under different circumstances. So here we found that after knocking down both the PDBP1 and 2, we can see the decrease of the NMD exon inclusion and the increase of the productive transcripts. However, if we overexpress the PDBP1 into the mouse primary neurons, we can see which are labeled by the red color. Then this overexpression of PDBP1s will repress the SYNGAP1's protein expression. So these results indicated that the SYNGAP1 NMD exons and expression are regulated by the PDBP1 and 2. So this is the in vitro evidence. And then we move on to test these NMD exons in vivo. So to do so, we generated a mouse models by deleting the NMD exon via the CRISPR-Cas9 system. So here's in this mouse model, the allele without the NMD exons is called the neuron-enriched isoform, or the NISO allele. We call it because we found that in the homozygous NISO mice, there's no NMD exon inclusion. There's only neuron-enriched isoform, which has no NMD exon inclusion. And importantly, the deletion of these NMD exons can improve the protein level of the SYNGAP1. Here we can see both the heterozygote mice and the homozygote mice have the elevated SYNGAP1 protein expression. So now we know that the healthy allele of SYNGAP1s can have two different splicing patterns. One will be degraded by the NMD, and the another ones can be translated into the proteins and then exert the functions in the human brain. And we found that in both in vivo evidence show that deleting these NMD exons can improve the functional isoform. So since these NISO alleles can express the SYNGAP1s more strongly, we wonder whether we can use these alleles to alleviate the haploinsufficiency. Our first idea was to replace these Y-type allele with this NISO allele with stronger expression. So here is how we do this. So this is the breeding strategies to generate the compound heterozygote mice. We first mediated the SYNGAP1 heterozygote knockouts by the EMX1 CRIS and the LOXP size. So this is the, we can see about 50% reduction of the SYNGAP1 proteins in the heterozygote knockout mice. And then we bred the heterozygote NISO mice with the heterozygote knockout mice. So in their progenies, we will have the wild-type mice as the control group, and then the heterozygote knockout mice as the disease model. And the compound heterozygote mice with both the SYNGAP1 knockouts and the NISO allele as the rescue group. And then we perform assays to characterize their neuronal functions in these three genotypes. So these results are collaborations with the Alfredo Garcia labs in Chicago. Here, we try to use the electrophysiological assays to test the long-term potentiations in the mouse hippocampus. So here we found that the heterozygote knockout mice is indicated by the blue color, and the wild-type mice is indicated by the white color. We can see a very clear reduction of the LTP expressions in the mouse hippocampus. And very encouragingly, we can see that the rescue group mice can have almost the same expression of the long-term potentiations in the mouse hippocampus. So it means that the NISO alleles can alleviate the LTP deficits in the mouse model. Additionally, we collaborated with Christian Hansel at U Chicago to perform another assays to validate the rescue effects. So here's we recorded the neuronal membrane excitabilities in the mouse cortex. And here we can see, so this is a signal from the single neuron. And here we can see in the heterozygote knockout mice, there's a very severe reduction of the excitabilities compared to the wild-type mice. And then in the rescue group, we can see the alleviations of the deficits. So taken together, these results indicated that the NISO alleles can indeed improve the mouse synaptic plasticity. So this is the evidence from the mouse, and the human cells are quite different from the mouse model. So to precisely regulate the Singapore-1's NMD exon splicings, we turn to the splice switching oligonucleotide, the SSO. So SSO is a kind of single-stranded DNA that can bind to the pre-mRNAs and regulate the splicing of the target. So the SSO is under intense investigations in many diseases, including the SMAs, the Batten disease, the AT disease, Dravet syndromes, and many other conditions. And very encouragingly, the nusinersen SSO has been approved by the FDA and is helping many, many people with the SMA. So in the Singapore-1 case, we need to improve the Singapore-1 expression. So we need to inhibit the inclusion of this NMD exon. Here, we screen a series of SSOs upstream of this NMD exon. And we identify one of it, we call it CH937, to be the most promising. So this SSO can not only decrease the NMD exon inclusion, but also increase the functional isoform. We validated the effects in another 3 iPS cell lines, including 1 cell line from the Singapore-1 patient. And importantly, we use these SSOs into the human brain organoid model. And these SSOs can increase the protein expressions in this organoid model. So this is the data from our study. And now we are working on the mouse models to test the SSOs in vivo. And we hope our studies can someday help to develop the novel therapies for patients with SINGAP1 mutation. And finally, I want to thank my mentors, our collaborators, and the funding support our studies, especially the Margaret Hackett Family Program. And thank you for attending. Yeah, good question. So actually, we can learn from many published studies. So we can introduce the SSOs into the mouse ventricles. And some studies also introduce the SSOs into the fourth ventricles to target different brain regions. So for this study, we have done some pilot experiments. We introduced the SSOs into the lateral ventricles at the postnatal day 2, and then collected sample from day 7, 5 days after injections. And our pilot experiments show that the SSOs is quite safe in the mouse bodies, and we are going to detect more samples to show the RNA and protein as well as the functional results. So these NMD exons can be used to regulate almost all kinds of mutations. Yeah, it is not mutation specific or allele specific. It's gene specific. Yeah. So did I address your question? Yeah. Yeah. Yeah, very good question. So here maybe we can go back to this slide. So actually, there is huge enthusiasm in the field of SSO, and actually here we use the splice switching oligonucleotides. So this kind of SSOs is to regulate the splicing abnormalities. So actually many diseases are caused by the splicing abnormalities, and another way we can think is that the SSO can not only regulate the splicing, it can also directly improve or decrease the RNA's targeting. So it can be used to many other diseases, such as the Betten's, AT's, Dravet syndromes, as well as the Timothy syndromes published several weeks ago. Thank you. Thank you.
Okay, well, that concludes our program for the day. You know, really fantastic, everything from very, very basic science, RNA, DNA, protein work, all the way to clinical studies, imaging studies, to AI. So I think we really span the full gamut, and you know, individual patient related care and patient advocacy and stuff. So it's been a great day. I know very long, and many of you are very tired. Thanks very much for coming. Thank you very much to Bill, Raynell, Margaret, for all that you've done for patients with multiple conditions. It's really, I mean, it's great, and I can't say enough for that. Thank you very much to the speakers. You know, really nice, the guest speakers from coming from all over the country, consortium members, and the ones who aren't here as well, the board, and everybody else. You know, I think that, you know, clearly we have to thank Julie, Jesse, Julie really for, you know, laying everything on, you know, making sure everything runs, getting everything set up. It's been, it's a, you know, really, you know, kind of thankless task in many ways. Thank you very much. And that's it. I don't want to say too much. It's a long day, and thank you very much. See you all next year.
Will benefit. We'll see if we can figure that out. All of the work I'm going to talk about today is essentially 10 years of work that we've done in Alabama, but that's standing on the shoulders of the giants in this field, and that includes this man who everyone in this room certainly knows. I met Dr. Frim when I was a resident in Madison. He's at all the meetings. He's always at the podium, or always at the microphone asking insightful questions. When I attended the ASPN, which is the neurosurgery organization, pediatric neurosurgery for the more senior members of our field, I went for the first time. And I showed up in a suit and a tie, and didn't realize that that organization, people give talks in shorts and flip-flops. So I was way overdressed. And after my talk, Dr. Frim came up to me and said, you look good, don't feel bad about this. And he gave me this bow tie that I am wearing right now. I've never worn this bow tie before, but I figured it was the perfect opportunity to wear this tie today. Okay, so let's talk about Chiari. You guys know about Chiari, right? This guy, Hans Chiari, the person who gets credit for describing the Chiari malformation. The paper that he published was in 1881. The title of this is actually changes to the cerebellum pons medulla due to hydrocephalus of the cerebrum. So he wasn't talking about Chiari. He was talking about hydrocephalus and the changes that come from that. Nevertheless, he gets the credit. And one more bit of history. The team in Birmingham, Shane Tubbs in particular, dug up this little bit of history. This is Dr. Van Huwinga Grafjik. He's from the Netherlands. He probably did the first operation for Chiari decompression, although technically it was a Chiari 2 decompression. It was an attempt to treat the hydrocephalus, which was in the 1930s. The patient eventually died because it didn't treat the hydrocephalus. But okay, enough about the history. So what is Chiari 1 malformation? Right? We have a pretty good idea now what we call Chiari 1 malformation. It has to do with essentially too much tissue in the posterior fossa and cerebellar position outside of the foramen magnum. I asked ChatGPT to give me a picture of what a Chiari malformation was, and this is what it came up with. This is totally ridiculous, of course. I love the hallucinated labels that it puts on structures. So, okay, I asked it then, you can do better than this. Maybe make it an MRI scan, and maybe that'll be easier for you. And of course, Chiari has to do with cerebellar tissue in the outside of the brain in the cervical spinal canal. So it gave me this. Coronal MRI with a cerebellum off to the side, and then 2 more cerebellums down in the cervical spine. So clearly AI is not going to be the solution to this. But there is a tremendous amount of variety in Chiari, right? These are actual patients, and you can see there's different shapes and sizes of the cerebellum, tonsils, et cetera. So in general, we tend to define Chiari as a tonsil position more than 5 millimeters outside the foramen magnum. Where do we come up with that definition? That comes from really 2 papers in the 1980s, the most famous of which by Barkovich And those were series of about 20 to 30 patients. And the ones that they saw had symptoms of Chiari, had cerebellar tonsils below 5 millimeters, and the ones that didn't have symptoms were above 5 millimeters. So they just drew that line and said, okay, we're gonna do 5 millimeters. And that's now become the definition. It's used by essentially everybody, but it's really not based on anything terribly robust. But if we use that 5 millimeter cutoff and we go to the general population, there's a couple of studies. These happen to be this one happens to be out of the Netherlands. There's one on adults out of the Netherlands as well. We know that the incidence of Chiari malformation is about 1% of the general population using that 5 millimeter cutoff. If you look at a hospital-based series, and the group in Michigan did this, so they pulled a random sample of about 2,500 MRI scans out of their 64,000 MRI scan database. And they looked for Chiari, and using that definition, they got a 3.6% of kids in their sample had tonsil position below 5 millimeters. Also from Michigan, they've done great work on this. So you can see if you just measure the tonsil position in that huge sample of Chiari patient or of MRI scans, you see that there's a normal distribution of tonsil position with a little bit of a tail off to the right, people that have tonsils even lower. But like anything else in medicine, there's a variation in where the tonsils are. And you can see here that that's slightly lower for age, or slightly lower down for age 0 to 10, different for age 10 to 20. So they followed that up with this study where they categorized tonsil position by age, and you can see that it changes over time. So they may, as the brain grows, and cranium gets a little bit fuller, and as the patient ages, the brain shrinks a little bit. Right? So all of this to say, there's a lot of variation and a lot of subjectivity, perhaps, in diagnosis. So we take all the children. I'm a pediatric neurosurgeon, so we're going to talk about children. If we take all the children in the world or in the country represented by this sample, we'll say that 3% of them have Chiari malformation. Well, it's the most common symptom that we think of with Chiari. It's typically headache, and about 40% of kids have headache. So our job is to figure out this little slice of the pie here that the Chiari causes the headache and where we can help. So to do this, right, as a young person coming out of training like myself, I am dependent upon the people ahead of me who will benefit from Chiari surgery. I get that knowledge from the people I train with. So I did residency in Madison, Wisconsin with Benny Iskandar. Benny himself was trained by Jerry Oakes for his fellowship. So then I went on to train with Oakes. So I very much practice in the Oakes philosophy. And you get surgery for Chiari if you have syringomyelia or a posterior tussive headache, right? Headache that's made worse with coughing, sneezing, valsalva, et cetera. Now, for these conditions, you get surgery. For other stuff, not so much, right? So other types of headache, Dr. Oakes would not offer Chiari decompression. And then he published this. This is one of Dr. Oakes' classic papers from 2011. So the first 500, so, like the old school, right? You get to a certain number and you publish it. So he got 500 Chiari malformations under his belt and published this paper. And about 50% of the patients in this series had syringomyelia. About the same number had a posterior tussive headache. The results were pretty good. And there you have it. So that's how we practice in Birmingham. But if you're practicing only based on those two symptoms, right, maybe there's something that we're missing. And one of Dr. Frim's great contributions to Chiari work is the Chicago Chiari Outcome Scale. And so you can see, right, this has a lot to do with, did you get better after surgery? There's 4 categories that go into the outcome scale. All of them are graded post-op based, how are you doing compared to pre-op? And you get a score from 4, which is terrible, to 16, which is excellent. Right, and so then the group here used that scale to follow a bunch of patients that had surgery. And here you see a list of all the symptoms that they had before surgery. Sure, tussive valsalva headache is on there. But there's a bunch of other symptoms on here too. And while the conclusion of this paper is that posterior tussive headache and neck pain are the most likely to get better, they're about the same level of success as all these other symptoms. So again, if we're practicing based on the Oakes model alone, we're missing patients that might be helpful. So let's see first step, and then we'll talk about kind of what we've done in Birmingham over the last 10 years. I want to try to answer this question. We'll do it through the literature. So I had 2 very excited, enterprising residents that said, we're going to do a big systematic review. And the purpose of this review is to determine if there's any imaging findings that we can look at pre-op that will determine number one question, are there imaging findings that will predict who's symptomatic and who's not? Number two question is, can we predict the need for surgery based on imaging? As you can see, they found no papers that actually address that. And then the third one, can we look at imaging findings and determine who's going to get better after surgery? Right? In that first question, with those 8 papers, they were all over the place. So we really can't draw any meaningful conclusions from them. No papers talked about the second one. But that third question, who's going to get better after surgery? There were a couple of themes. One was about basilar invagination, the other syringomyelia. But if you put them all together and do the meta-analysis, you see that all these confidence intervals generally cross that 1.0. So bottom line here is you can't really use what's in the literature to pull out imaging findings that are going to predict surgical benefit. So of course, we've looked at the literature where we figure it's not there. So maybe we can do it ourselves, right? We'll use our series in order to try to answer this question. And fortunately, again, I'm practicing in Birmingham where we have this giant Chiari experience thanks to Dr. Oakes. So again, we leverage the work power of the residents and the medical students to go combing through our medical records and find all the patients that we have evaluated for Chiari malformation in the last 20 years or so. And you can see the flow chart of the patients there. We get down to a sample of about 730 patients who we have pretty good detailed imaging data on and knowledge of what happens. And again, the purpose of this paper now is to determine, are there imaging findings that are available pre-op that are going to predict whether or not you have surgery? And remember, that's whether or not you have surgery in the Jerry Oakes models, right? So syringomyelia and posterior tussive headache. And here's the results. Again, if we're operating for syringomyelia, obviously syringomyelia is going to be a significant factor. Nothing else is super helpful, but I will point out that tonsil position is on the list, right? So lower tonsil position means more likely to have surgery. So maybe we can use that as a cutoff. Well, it turns out we absolutely cannot, right? So here's the overlap of the tonsil position of patients who had surgery versus those that didn't have surgery. And you can see that there's a ton of overlap. So drawing a cutoff line here is not really possible. So once again, we're back to that conclusion that I have no idea how to predict who's going to get better based on imaging, just like the literature told us. So therefore, we're stuck. We have to go based on symptoms. But what if you don't meet Dr. Oakes' criteria for surgery? Right? We have 2 now. I think that's what comes next on my slide. We have 2 questions. Right, there we go. Will I get worse if I don't have these symptoms now at the time of presentation? And what about other symptoms? And let's address these questions in order. So will I get worse? In order to answer this question, fortunately, the long experience with Chiari patients in Birmingham, I think it is useful for helping to answer that, because all you really need is a big cohort of patients that you followed over a long time. And again, fortunately, Dr. Oakes had this clinical follow-up protocol. If you were in his office for a Chiari evaluation and you did not meet his criteria for surgery, he'd have you come back for an MRI scan in a year, another visit. And then if that was okay, he'd double that interval of follow-up and keep doubling it until the patient was too old to come to children's anymore. So we have this follow-up at 1, 3, 7 years, et cetera, after presentation. So what happened? Well, this study, we defined a benign Chiari malformation as somebody who does not have posterior tussive headache, does not have lower cranial nerve dysfunction, and has no evidence of syringomyelia on their imaging. Right? So that's our cohort of benign Chiari patients. And then we followed those patients, again, this is retrospective, so we followed them along. We had a total of, as you can see, 260 that had surgery within 9 months of their first visit, right? This is a retrospective study, so we have to define, I don't know for sure what their symptoms were, but if they had surgery within 9 months of that first visit, we figure, okay, they must have met Dr. Oakes' criteria, relatively soon after the visit. So we end up with a total of 420 patients who met our definition of a benign Chiari. So what happens to them over time? You can see the mean follow-up here was 3 years. That's the composition of the sample. More than 300 patients had a year of follow-up. More than 100 patients had more than 5 years of follow-up. And in total, we had 15 patients who went on to have surgery later on down the line. So that's 3.5% of the sample. So that's pretty small. Looking at those patients in more detail, what symptoms did they develop later? You can see the list here. It adds up to more than 15. There's some overlap. But delving into it a little bit more, yeah, our usual trick, are there things that we can do to predict who's going to be in that get surgery later category? No, there are not. All of these odds ratios, confidence intervals cross one. Here's the Kaplan-Meier curve. Note that the scale there starts at 0.75 at the bottom. That's not 0 to 100, so that's really the top part of the Kaplan-Meier curve stretched out. So over time, most of these patients are not having surgery. So that leads us to the question, right? Do we even need to follow these patients? If you don't have these symptoms when we meet you, or you're not going to develop them, do we need to follow the patients? And for this, I'm not going to give you an answer to this question, but I'll just give you some data to help think about it. Here are the 15 patients who went on to have surgery. And I want to point out 3 of them who developed a syrinx on follow-up without any other types of symptoms, right? So these are patients that we would have missed if we had not been following them. So syrinx with no symptoms. So 3 out of 300 or so, that's 1%. Is that justification for follow-up? Up to you. You get to make that decision. We do continue to follow these patients in our center. I want to point out one other thing here on this graph, and that is this category here. All of the patients who went on to have surgery, who developed later symptoms, were white and had private insurance for the most part. So this finding led to our next study, and this one was led by Hassan Akbari, who was our fellow in Birmingham in 2020, 2021. So do we have a disparities problem, right? If we're only operating on the white and privately insured patients, what does that mean? We live in Alabama. Population is about 25% Black, about 8% Hispanic. So he took, again, our large sample that we've made a lot of hay out of over these last 10 years, and now went through and pulled the addresses for all the patients, geocoded them, mainly on these two metrics, the ADI, which is the Area Deprivation Index. Right, so a higher number on the ADI means you come from a more deprived part of the country, right? So that's based on 17 different factors like, plumbing, cell phone usage, internet availability, local income, et cetera. So it's census tract based. And then the RUCA, R-U-C-A, is the Rural Urban Commuter Area Code. So that defines how close to a major city you are. And what we find is that overall, for that group, about 30% of patients end up with surgery. Like, we knew this already because we've already looked at this sample. But there's no difference based on age, or based on race, ethnicity, area deprivation, RUCA, for who gets surgery immediately, right? So that makes me feel good. Our center is, once you show up in our doors, we're treating everybody the same. Good deal. But what about those patients that got surgery later? So I'll focus on that last column there, delayed symptoms. And you can see that we don't have a significant, although there is a bit of a trend towards more white patients, more privately insured patients. But we do see a significant difference in area deprivation index and rurality. Right? They are less deprived, if you will, if they're coming in for repeat surgery later. What I take away from this is that it's incumbent upon us as a center to make sure that we're providing the resources necessary to get patients back and follow up. And to some extent, this is obviously something we need to do way beyond Chiari. And so we work on a number of different programs now to do this, and beyond the scope of this talk. But nevertheless, those are our findings. So to date, what we've discussed, we'll come back to the beginning. Will I get worse if I don't have these symptoms to begin with? And the answer is probably not. But what about other symptoms? And I want to talk about one other symptom, and that is sleep apnea. So this is something that there's a pretty good link in the literature between Chiari-1 and sleep apnea. There's a pretty good number of small single institution series that compare Chiari patients that have had polysomnography. So what can we add to this? Well, again, we have a lot of patients. And the thing that I think is unique about the study that we've just finished and just been submitted for publication is this left box here, 232 patients who underwent sleep study just because they had a Chiari. Right? So most of the rest of the literature, it's the patients happen to have a sleep study probably because they had snoring, pauses in breathing, things that their parents had noticed that led the providers to say, okay, do I need to screen for sleep apnea? And we had 78 of those patients in this group out of the 310, but most of them are patients that we sent for sleep screening just because they had a Chiari. Now, why did we do that? Well, it turns out we've also had some experience with myelomeningocele spina bifida, and we had done a prevalence screening study in that population in our spina bifida clinic, sending everybody who had never had a sleep study in for a study, and found about 40% of those kids had sleep apnea. So the group is thinking about sleep a lot. So we get the Chiari patients in and say, okay, we probably need to screen them for sleep apnea. So anyway, that's my justification for why this is an interesting study, despite the fact that it's been published on many times in the past. And we found 147 of those 310 had sleep apnea, sleep disordered breathing. So that's a prevalence of 47%. You can see the confidence intervals there. That's a lot of patients. Right? So my argument here is that kids with Chiari, probably it's justified to send them for a sleep study to screen for sleep apnea. And you can see the apnea type there, central, obstructive, mixed, or unspecified sleep apnea. A lot of central apnea, a fair amount of obstructive apnea as well. What do we do with this information, right? If a child has a Chiari-1 malformation and obstructive apnea, do we use that as a reason to do a Chiari decompression, or do they just have their tonsils out? I don't have the answer to that question. That's the next study we need to do. Again, are any of these factors related to the presence of sleep apnea? Turns out, yes, if you have lower cranial nerve dysfunction on exam, yep, tonsil position is significantly related, things that you might expect. BMI, right? Larger kids have more sleep apnea. But importantly, we had 47 patients who had no symptoms of Chiari, right? They had no complaints whatsoever, just Chiari on imaging in that cohort of 310. And of those 47, 27 of them had sleep apnea when we sent them for their polysomnography, right? So that's a little bit more concerning, right? Why would they have sleep apnea? They have no other symptoms. Maybe it's just from the Chiari. And so the last thing on this study that we can pull out is, does Chiari decompression help? And the answer to that seems to be yes. You can see that the AHI, or apnea-hypopnea index, that's the number of apneic events, the number of hypoventilatory events divided by the hours of sleep. There's a significant decrease from before surgery to after surgery for this, again, small sample here, 34 patients in this group that had sleep studies both before and after Chiari decompression surgery. I will say that none of the children that are in this 34 also had tonsillectomies, right? That's an important point. We made sure to check for that. Some of them went on to have tonsillectomies later, but between the two sleep studies that bracketed the Chiari surgery, the only thing that happened in there was Chiari surgery. Right? So maybe we can make a difference on sleep apnea with Chiari surgery. Okay, so what other symptoms might be beneficial here? I'm going to go through just a couple of cases. This is an 11-year-old girl. She has unilateral headaches. They last for hours. They're associated with photophobia. So these are pretty classic migraine headaches. This is somebody that is very unlikely to get a Chiari decompression surgery in our hospital. Oh, but wait, there's the rest of her image. She's got this cervical syringomyelia. That completely changes the game, right? Now this is somebody who does meet our criteria for Chiari surgery. And these are not her pictures, but these are related or similar pictures. You can see we actually did find in this patient a arachnoid veil, which you can see on the left there, obstructing the outlet of the fourth ventricle. Again, Dr. Oakes' data, about 8 to 10% of kids with syringomyelia have an arachnoid veil obstructing the outlet of the fourth ventricle. So reason to do an intradural exploration. To date, this child is a couple weeks out from surgery. She's had a change in the frequency of her migraines. They haven't completely gone away. She's still gotten a couple of them, but they're a lot less common than they were before the surgery. So can Chiari surgery help with, non-traditional Chiari type, non-Chiari type headaches? I don't know the answer. Here's another case. This is a nearly 2-year-old boy. His main complaints are swallowing difficulties. He's been diagnosed with eosinophilic esophagitis. He had a sleep study. His apnea-hypopnea index is 2.0. So that's not normal, but it's not particularly severe. Over 5 is what we consider to be reasonably bad. He's not very coordinated, but he's 2. And his parents really don't like the way he behaves. So here's his study. This was interpreted by our radiologist as crowding at the posterior fossa. Now, I don't know that that's particularly crowded. We did not offer him a Chiari decompression surgery at our hospital. They went and looked at it, got a second opinion at another center that does a fair amount of Chiari, and they did, in fact, offer him a decompression. I don't think he's had it, and I don't have any follow-up on this yet, but it's something to think about. And finally, the last case here, this is an 8-year-old who's had 3 months of headaches. She had an opto exam, found to have papilledema. She clearly has, crowding at the posterior fossa. Her tonsils are well down into her cervical canal. You can see the beginnings of a syrinx there. And so Chiari decompression. Well, actually, no, we just did an ETV because she had big ventricles as well. And here's her study just about 2 weeks after her ETV. So the syrinx is gone, the tonsils are up, the fourth ventricle smaller. Just treat the hydrocephalus and she's better. Right, so I go through all this to point out that there are clearly other symptoms that Chiari can cause that don't fall into that classic definition that we use. If you do this is an internet search for Chiari word cloud. This is generated by a group called Stuff That Works. They ask questions, they get kind of a crowdsourced answer, and these are the things that you get if you search for Chiari on the internet. None of these are things that we would operate on in Birmingham at present. Are there symptoms here that might get better with a Chiari operation? Well, certainly there might be. If we go to the literature, you can see the number of publications linking Chiari with fibromyalgia, autism, Ehlers-Danlos. These are things that people are thinking about, writing about. But can you draw any reasonable conclusions from these papers? I would argue it'd be pretty difficult. So the bottom line is, are we missing Chiari patients that we could help with surgery with our fairly limited, rigid view of Chiari that we practice with in Birmingham? And then I think a lot of other practices use as well. And I don't have an answer to that question. Here's my plug for the Chiari Syringomyelia Foundation. This is a group that has assembled a bunch of different centers. You can see all their logos here to do what's called a Chiari Surgical Success Score study. Now, this is a fairly limited study because we have no money. It's not funded. So we have to do this based on the resources that are available at each center. But we're enrolling all of the patients that have Chiari surgery at each of these centers and following them up for a year with the goal of figuring out have they gotten better from their primary symptoms a year later. And what were those primary symptoms, right? So it's a bit of an observational study. It's only following the surgical patients. But hopefully, if we have enough variation in the way people practice at these various institutions, we might learn something from them. But what do we really need? And that's a much bigger study. I would argue that to get to this, we're never going to do an RCT. The rigorous criteria that would be needed for an RCT are going to be too rigorous or too limiting to learn the answer to the questions we need to learn. What we need is a big registry with multiple centers that practice Chiari medicine slightly differently, varying different thresholds for surgery, indication for surgeries. We need to follow all of the patients, and we need to follow them over a reasonably long time, at least a couple of years, whether they've had surgery or not. And we need to capture any crossover as well. So if you see me and you don't like my answer, and I don't give you a Chiari operation, you go to somebody else and you do get a Chiari operation and you get better. I want to learn from that. And the only way we're going to do that is if we have a way to track this independently. And independent follow-up here, I think, is key, because if you see me and I don't offer you a Chiari surgery and I enroll you in this study and you go have surgery somewhere else, how excited are you going to be when my team calls you in 2 years and say, how you doing? Well, maybe not that excited. But if we have an organization like the Chiari Syringomyelia Foundation, who I do work with, or potentially the Hackett family program, right, that would be you're probably going to get a lot better response from the participants. So I would argue that that's what we need. That's what we need to be shooting for, going forward. It's a big ask. It's going to be hard to do without substantial funding, but that's the plan for the future. So with that, I think I'll stop and hopefully take questions. This is work I presented here has happened over the last 10 years at Birmingham with an army of medical students, residents, and partners, all of them here. And of course, this is my family, and I get to show a picture of them. It's not show a picture of your family. Right? So with that, I'll stop and take questions. Thank you so much. Voice. Yes, so I don't have that breakdown on a slide for you, but you saw it's about 30% had obstructive, 30% had central, and a fair amount mixed. And we saw improvement in all types of sleep apnea after Chiari surgery. My theory on this would be, and we certainly see that in the myelo population as well, and I'll take a quick veering off into spina bifida. we just finished a study on follow-up after treatment for kids with myelomeningocele and sleep apnea. And what we found, again, it's a pretty small study, but they have a much lower response to tonsil and adenoidectomy than you would expect. And pediatric sleep apnea is an ENT disease. You take the tonsils out and you fix the obstructive apnea. But that doesn't necessarily work in myelomeningocele. And our theory for this is that it's brainstem dysfunction, there's KRI2 malformation, there's cranial nerve nuclei, that you have a lower airway tone leading to that obstructive apnea. So I would posit that perhaps it's the same kind of mechanism in KRI1. And if you decompress the brainstem, maybe you can help with obstructive apnea too. I don't have an answer to that question off the top of my head. It's a great question, but I can't tell you. So that's a very interesting idea, right? The genetics of posterior fossa development may be more closely linked to jaw development, and therefore they have a small mouth and a higher risk for obstructive apnea. That's a fine theory. I have no way to speak to that. Yeah, that's interesting. That's the position we've really come to in Birmingham. We send everybody for a sleep study. The sleep doctors are overwhelmed, but they'll figure it out. Yeah, yeah. Tina. It's 3 or 4 months, unless if it's somebody urgent, we can call up and they'll get them in sooner. But it's a long time, and so be it. If the patient don't have any other symptoms, I'm okay to wait on that. And, we're going to get a follow-up image maybe in a year anyway. So as long as they come back at some point with their sleep study, I think we're okay. Yeah, we've also, back to myelomeningocele, we've been pushing really hard on getting kids with myelo screened. So we're doing sleep studies on every newborn in the NICU, and they all have sleep apnea. It's ridiculous. But all of that has led to a bit of a log jam in the sleep lab. So not everyone. If you have a big searing tussive headaches, I'm going to operate on you anyway. I don't necessarily do a sleep study in advance. Right? So if you already meet criteria for surgery, it's not going to help us with decision making. We don't do a sleep study. Actually, I don't usually. Maybe I should be. Yeah.
Yes. Before you come, your slides were up. So someone asked me, what does it mean? Who benefits from the operation?
Mm-hmm.
And he is a scientist, not a clinician. So I gave a philosophical. I said the person who benefit most is the patient. And then the parents. And then the society. Millions of dollars spent for society, for people who have hydrocephalus and a society. But I have a clinical comment. I learned years ago not to open the duro.
Mm-hmm.
My idea came from Edgar Kahn, who was you may know him, he was a German at Michigan. He first, for stenosis of a spinal canal, he said that you open the duro and leave the duro. And then a lot of infection developed, CSF developed. Then he was one of the most honest person. He retracted his comment and said we shouldn't open necessarily. So I learned not to open the duro in that. And among those that you presented from University of Chicago was my series of not opening. And immediate result was that the patient whom we don't open the duro, they do better from the point, less CSF leak, less bulging here. And if you ever go back to the patients who have had posterior fossa for tumor or crane, you find a lot of adhesion. And those adhesion causes symptom and hydrocephalus, which is in there. So I followed those patients that I didn't open the dura. They do far better, but have not followed by an independent person who has no back. So I was wondering, what do you think about not opening the dura?
It's a great question, and we've just finished a very large randomized trial on opening the dura versus bone-only decompression in Chiari. It was something like 50 sites. They were randomized at the level of the site, so each center that participated was randomized to either bone-only or duroplasty, and the results are approximately equivalent. That's not quite published yet, right? But it's been talked about, so I'm allowed to talk about it. Yeah. The complication rate is going to be higher if you open the dura, right? Higher rate of CSF leak, potentially inflammatory meningitis. But the redo rate seems to be lower, right? As I showed there, there's about 8 to 10% of patients that have that arachnoid veil obstructing the outlet of the fourth ventricle. And if you don't do a duroplasty, you're never going to see that. So in the OAKS series, those patients with that arachnoid veil, you don't explore, they're gonna have a redo operation because their syrinx isn't gonna come down. So that's about 8%. So the way Jerry Osel has explained this was, if your complication rate with a duroplasty is less than 8%, then you should be doing a duroplasty. If your complication rate is higher than 8%, you should be doing a bone only. So,
because the one question is raised is that Chiari is not a problem of cerebellum. The Chiari is a problem of posterior fossa, that it is soft, that it is hard and it's small. It's some form of, it looks like a craniosynostosis of posterior fossa. But when you operate, you find out how thick it is, the bone, and how small the posterior. So if you open it widely, or maybe this is sufficient rather than.
Right, or maybe a bigger bone only is the answer. I don't have an answer to that question. I will say that personally, I think that the symptoms from Chiari come from, it's a CSF problem, right? There's not adequate movement of CSF with each pulsation of the heart. And so for me, if I have a redo Chiari or difficult Chiari, the solution, the ultimate solution, is to put a stent into the fourth ventricle with one end in the fourth, the other end in the cervical subarachnoid space. Those patients all seem to get better, right? Their symptoms go away, their syrinx gets smaller. So that's my final common pathway. If everything else fails, well, put the little tube in and they get better. So I personally think it's a CSF issue primarily. Now, whatever you do to make the CSF better is going to make the patient better. Yeah. Right? Yeah. Right. We don't use them in Birmingham at all. We did use them a little bit in Madison, Wisconsin. So the radiologist there, Vic Houghton, was really big into studying CSF flow. There's a lot of papers on that. They say a lot of conflicting things. I personally don't find them super useful for surgical decision making, but I know that there's groups that swear by it, and using ultrasound to check the tonsil movement and using that as a basis for opening the dura. Very reasonable ideas. I don't have an answer. Yeah.
One thing that we struggle with is the syrinx related to Chiari? And I noticed a couple of the patients had, a small 4 millimeter cervical syrinx. If that was 4 millimeter syrinx in the thoracic spine, is that Chiari related?
Right, yeah.
There's really not great publications on that.
There's not.
A couple showed that the cervical spine syrinx are related, but if you have someone who's asymptomatic, no headaches, no other problems, and then they have, 4 millimeter thoracic syrinx.
Yeah.
Is that related? And then, the idea of brain fog. I have a lot of patients come in is that related? So people say it gets better.
Yeah, I think great thoughts. And so we don't have great data on this, as you know, right? The Park Reeves study, the randomized trial, you had to have a syrinx at least 3 millimeters in order to even, be considered for part of that. And again, that's so we have an easy outcome to follow. Right? Did the syrinx get smaller? That's easy to tell. Personally, in my practice, 3 or 4 millimeter thoracic syrinx with no other symptoms, I'm going to see you back in 6 months or a year and repeat your imaging. And if it never changes, I'm probably not going to offer you an operation. I would venture a guess. We talk about brain fog a bit, and you see those word clouds, all those kind of vague symptoms. I sometimes wonder if that might be related to sleep apnea. Right? So a brain fog patient would absolutely be getting a sleep study in our hospital. Yep. Yeah. Yeah. No. Thank you very much. Really appreciate the opportunity.
All right, everyone, good morning. As Dr. Yamini just stated, my name is Ashley Johnson. I am the Outreach and Engagement Manager for the Margaret Hackett Family Program. And so I'm going to give a little bit of information to you all about this arm of the program, the value that it brings, not just to individuals who are walking with these conditions, but their families, and then your role that you play in these sources. So to start off, again, I am not disclosing any financial relationships. I won't be discussing any type of investigational use in my presentation. So as many of you are aware of and you're learning about today, the Margaret Hackett Family Program, it really emphasizes the importance of advocacy and support resources for both pediatric and adults in need. And so when we talk about resources and we talk about support, we're really going to dive into the value that they bring and then specifically what our program really wants to venture out and focus into. So when we think about resources, what we really want to touch on is the fact that we partner at the Margaret Hackett Family Program with a variety of organizations, different spaces throughout the country to provide connection, to provide social opportunity and resources. So just super high level, if you break it down, we really have programming and resources into 6 different categories. So that starts with our adult programming. We have connect groups, which we are going to talk about a little bit more later on, fitness events, even caseworker details, but then we also go into living assistance, right? So for a lot of individuals who are living with these conditions, Chiari, hydrocephalus, spina bifida, et cetera, a lot of them are figuring out what do I do in transitioning from living dependently, possibly with a support system, with family, into how do I enter society as an independent and empowered individual. And so we walk alongside those individuals with resources such as ways to get employment, grocery support, legal resources. There are different things, again, that if you have been living in a space, right, where you have been dependent and you're walking into independence, there are basic things that sometimes you don't think about that individuals can use. We also focus in on child and teen programs. So that's resources such as adaptive sports. We partner with an amazing organization called Lincoln Way, who really focuses in on ways to give recreational and social opportunities for children and teens to use adaptive sports. So that's pretty much any sport you can think of. They have amazing opportunities and really great stories of people who have started off with adaptive sports for basketball, started off with even adaptive sports for swimming. And again, the empowerment that brings, right, to children and teens who are walking through conditions, right, who sometimes their everyday life is based around the hospital. When are appointments due? What day do I have to pick up this medication? It gives them a life and an understanding and a meaning and a purpose outside of their condition. We also have programming such as family care coordinators. Again, there's so many families who are new to this. I mean, a lot of you in this room have encountered families who are just recently diagnosed and they're looking for what are the next steps? What does my child need? What should I be expecting for a 5-year-old who's developing and possibly going into elementary school? So we have resources such as family care coordinators that we partner individuals with to see with where you are, how can we resource you? We also are very big on educational material. So again, there are not just new families, but there are new support systems who are just new to what is Chiari, what is hydrocephalus. So we make sure that we provide tons of educational materials. We also focus in on 504 and IEP plan. So that is a focus specifically for students. So for any child or teenager who is a part of an educational system, there's actually resources that can empower them and their families to specifically be on a road to success. Again, these are things we look over a lot, just thinking, okay, a child has a diagnosis, they may go to school, they may not, they may miss days, they may not, but that really impacts their ability to be able to thrive, not just in the everyday world, but as an adult. And so being able to have things such as a 504 or an IEP plan, what it does is it brings connection and relation to the parents, the individuals in the school, the administrators, and the student to say, for their specific diagnosis, for their specific condition, what can be the best way that we don't lower the bar, but we make sure the bar can meet them with where they are so that they can be on a road for success. And then also something that's very big for us is caregiver and family support. It genuinely takes an entire village in order to walk with an individual or a child through any of these conditions. So we're very big on making sure that those individuals who are walking with anyone who has a diagnosis is supported and cared for. And there are some of those resources there. Also, when it comes to resources, we want to be able to give individuals the tools to be empowered. And so what that looks like is we have an entire referral process. We make everything at the Margaret Hackett Family Program. Our goal is to make it super easy and super user-friendly. We want to be able to empower individuals and patients with resources. So what that looks like for us is that individuals, any of your patients, anyone that you know, they can literally head to the website when we have different events. There's a quick QR code that they scan and it brings them straight to a referral page. And what that referral page does is it gets the basic information of who they are, where they're located within the country, what their condition is, what's the specific resource that they're looking for. And then we partner and come alongside them to be able to provide them with the specific resource that can help them. Again, we want to give them tools that they can use to empower themselves. But a big part of empowering, a big part of support, a big part of resources is our connect groups. And so for us, connection really is the key to success. So when it comes to an individual with a CNS anomaly, we are really intentional about making sure that connection is made. Again, I spoke about how a lot of times with these conditions, life can be very much revolving around the hospital. Sometimes these individuals know the hospital a little bit more than they know home. And so we don't want to provide spaces that are a resource and then they step away and then they're sent out into the world by themselves. No, a big part of why Bill and Raynell Hackett were able to really push this foundation and really their vision was to be able to help other families. They were in a position where they didn't know where to go, they didn't know what to do, and so they were, able to come along the path of Dr. Frim. But a big thing for them was making sure that families and individuals didn't have to go through that process that they did, and especially that they didn't have to go through it alone. So that leads to our connect group. So one of those spaces might be a little familiar to someone in this room. Margaret Hackett is one of our connect group leaders. And so when we talk about a connect groups are small cell groups that allow individuals with these conditions and their support systems to have one-on-one connection. So what that looks like is on a monthly basis, these groups meet on the first Thursday of the month. They meet via a Zoom call to give flexibility. Again, if they're leaving a doctor's appointment, if they're traveling, if there may be things that are coming up, it gives for an easy point of connection. And so these individuals meet over a variety of topics, but then also they have social hangs. So this is an example. These are actually some of our connect group leaders in this picture, and this is when they went out for a bowling event. And so again, when we talk about adaptive, we want to talk about supporting, but we also want to talk about what is it like to live a full life with this condition. And that's what these connect groups are. They point people to that. And so with that, we want to create spaces for individuals to connect, receive support, and be strengthened. There is a lot of mental turmoil that can go on with feeling as if you're possibly alone, as feeling as if you're the only person dealing with these symptoms. And what we see in these connect groups is that so many times the conversation, may start off a little lighthearted, and then someone's talking about how the first time they got their diagnosis, and then you hear someone else saying, oh, wait, I thought I was the only one who felt that. Wait, that's what happened with your shunt? Oh my gosh, that feels so much better because I thought I was the only one. And you see them open up, you see them feel encouraged, and you see them feel hopeful, which is a key to making sure that they can be able to live a full life. So these connect groups also focus on specific topics. So over the last 6 months, we focused on a mixture of some of the connect groups are just social, where people get to talk. We also have connect groups specifically for parents and their support system. So they break out into 2 separate groups. Right now, you can even see an example of our group where we have a parent who's a part of one group and then their child is a part of another. And again, it gives them a space to share, because when you're walking through these, it can feel very lonely. It can feel very much like I'm the only one. And to be able to have a safe space where people understand you, you don't have to, water down all of the details of your condition or the medications you take. You have people who speak your language. And so within these connect groups, we've covered a variety of topics. We've had speakers come in to talk about how to manage pain. Even we've had one of our team members, our nurses, Judy, come in to even talk about navigating the healthcare system. Again, we talk about people who are looking to see, okay, now that I'm moving from peds to adults, what floor do I go to? Again, these are basic things that sometimes we overlook, but just empowering individuals with that information is extremely helpful. And then even we have topics that we're covering of how to find joy in tough situations. So when we talk about the goal, our goal is that every patient and caregiver feels and knows that they are not alone. But you all play an extremely important role in that. As their physicians, as their nurses, as some of you are support systems, some of you are students who are looking to grow in this field, you are a trusted space for them. You are people who, again, they sometimes see more than other people, and your knowledge of ways they can get connected, different resources that is useful to them, they will take that information sometimes over someone sitting at a table. So you just even being prepared with, hey, I don't have all the information, but I know you can go to the MHFP website and they will trust that, and they find confidence and safety in you and your knowledge of expertise. And so at the MHFP, we just want to be able, again, to partner with families. We want to be able to partner with caregivers, but we also want to be able to partner with you. That's why we've hosted this day, to be able to bring all of these minds in, because your research, your knowledge, your conversations are benefiting the future individuals who are going to be able to know that they're not alone. So thank you again for coming out, and we're just happy that you guys are here. Thanks.
Okay, great. All right. Well, it's just such a pleasure to be here today. I wear two hats, one as a child neurologist and one as a neurogeneticist. And so in my role as a neurogeneticist, we routinely evaluate kids who have developmental delays, have congenital anomalies, and we're trying to figure out the why, which is oftentimes genetic. But then the next steps are, how do we guide families through the process of raising a child with neurodevelopmental disabilities in that transition into adulthood? And so it really is just so heartwarming to hear about the work that the program is doing. I'm just delighted to be here today. So today I'm going to be talking about the work I do in my role as a child neurologist, as doing most of the prenatal neurology consultations at Hopkins, and what I've kind of learned over the years. And so I have no disclosures, and our goals today are to understand how we approach prenatal neurological counseling and understand kind of the range of the things and the limitations of what we can detect prenatally. Be aware of what these implications are about how we take care of the babies after they're born, and then be aware of those things that we can do that really do change our outcomes. So in terms of how the logistics of a prenatal neurological consultation is obtained, typically women will have second trimester anatomy scans between 17 and 21 weeks of gestation. And if there's a concern that is identified, they'll typically be referred to our maternal fetal medicine group. And then they'll repeat the scan, sometimes do what's called a dedicated neurosonogram if it's a CNS anomaly. And then they'll coordinate with our radiologist to do a fetal MRI, and then also involve me for a consultation. And so the big question is, how do we take a brain like this tiny little brain, in the second trimester, might be scanning between 22 and 26 weeks of gestation, and predict what's going to happen when the child is here and their brain is fully developed, and help give the family an understanding of what to expect for their child. Question is, well, how did I learn to do this? This is kind of esoteric stuff. Well, so my PhD is in developmental neuroscience. So I've always been interested in understanding how the genes control brain development. And then when I did my rotation as a medical student in OBGYN, like the best thing that I got out of it was spending time in the ultrasound lab. So understanding how we scanned and looked for prenatal anomalies. And then when I was a resident, I started my neurology resident 20 years ago in 2004. So I actually did a review of the database of anomalies that we had in the ultrasound lab to kind of better understand outcomes, and did a review of the literature. But back in this time era, you can see from the PubMed, there's really not much in the literature about prenatal neurology consultations. Most of the work that was being done came from Mark Scher at Rainbow Babies, who's now an emeritus professor, talking about the role of the neurologist in prenatal consultations. And this, over the last 20 years, has really blossomed. And so there actually are now fellowships in fetal neurology. And we think of this now as a continuum from the maternal fetal dyad into postnatal care of our infants. So there are some considerations, though. So the pregnant woman is technically your patient during the consultation, not the baby, even though you're going to be caring for the baby after the baby is born. And we always have to keep in mind the goals of the consultation. So early on, the woman may be looking for information to guide a decision about whether or not to continue the pregnancy. But later on, they may be looking for reassurance or trying to establish a postnatal care plan and meet the doctors who are going to be caring for her baby. So we do a lot of information gathering as part of a consultation, where to understand the reason for the referral, who's referring them to us, and their understanding of the condition. We need to know how far along in the pregnancy they are, any prior pregnancy history that might be relevant, any complications, if there is reproductive assistance. And then if there's been prenatal genetic testing, even non-invasive prenatal testing or amniocentesis, if there have been any in utero exposures that might be relevant, or such as medications or other, if the mother's medical history plays into it. We do a full pedigree in terms of understanding if there are any conditions that run in the family or similarly affected children. And then also, questions about travel, exposures to certain viruses and the like that can impact brain development. And then getting a better sense of kind of the psychosocial implications in terms of the support systems, where the baby's going to be delivered, and if it's a boy or a girl. It's important to know if there are other fetal anomalies, if those anomalies have been stable over time, and we look at the growth patterns in terms of the size of the baby, the head size and head shape, in formulating some of this. So in terms of thinking about a framework of how we approach this, there's something called a spikes framework that is relevant here. So the S is we set up the interview. P is the patient's perception. I is obtain an invitation to give information. K is to give knowledge. And then E is to address their emotions. And then S is for next steps. So going through this, when we set up the interview, I always introduce myself. I'm a child neurologist. I take care of kids who have differences in how their brains have developed, so they understand why I'm there. We confirm everybody who's in the room participating in the interview. And, certainly during COVID, this has certainly been very, video and television has been very conducive to this because we can share imaging on the screen and people can do this from the comfort of their home. Confirm the gestational age and, always ask, do you know if you're having a boy or a girl? Because you don't want to ruin any surprises. And then always ask if they've chosen a name for their baby, is helpful for the interview. Okay, and then we assess their understanding of the concerns at hand. So we kind of have an idea of what level we're coming at in terms of the counseling. And then I always ask about their experience with kids with neurodevelopmental issues, if there are family members who have been affected, if they've interfaced with special intervention services before, and understanding their background there. And then obtaining an invitation. You always check before we look at the fetal MRI together. Most people want to review it, but some people are kind of grossed out by seeing the MRI, and so we don't always review it. And then we provide knowledge, and these can be difficult consultations. We're responsible for turning what might be an abstract diagnosis into really what can be painful news in terms of what to anticipate about the future for their child. But our goal is to really educate them on the neurologic condition and understand how it may affect her baby and her baby's future. And then addressing their emotions. Parents always have a sense of guilt about what caused their baby's condition. And oftentimes we're able to provide reassurance that it's really not anything that they could have done differently. And then we talk about next steps in terms of what's going to happen after the baby is born, and then the longer term follow-up needs, and then always provide our contact information so that they can follow up if they have questions even before the baby has come in terms of things that they've learned about. So how do we approach outcomes? So it's really useful to kind of break it down in terms of different streams of development. We have our gross and fine motor, our expressive and receptive language, our cognitive and our social and emotional streams of development. And these streams can lag at different rates. And so it's helpful to look at each stream individually. And so we'll be talking about what we might anticipate for each stream of development based on the baby's condition. And sometimes we introduce some keywords that people will be asking about, things like cerebral palsy, talking about intellectual disability. When people hear the word that their child may be delayed, they oftentimes just assume that their baby is going to catch up. And sometimes we have to direct the conversation that a child may never actually catch up and they may have intellectual disability. Sometimes we'll be talking about the risk of seizures or epilepsy, blindness or cortical visual impairment, and asking questions like, well, can we predict, will my child walk? Will they talk? Will they be toilet trained? Will they be able to self-feed? And then we talk about the role of serial imaging, if there's need to do serial ultrasounds or repeat MRI to really firm up a diagnosis, and talking about goals of care after the baby is born. So sometimes the counseling is very straightforward, and it's very straightforward when we have normal variants and we can be reassuring. So for example, one thing we run across quite commonly is something called a Blake's pouch cyst. And so this is very basic for all the neurosurgeons here. But just to review, it's the cystic structure in the posterior fossa. This is outpouching the fourth ventricle that's supposed to perforate to form the foramen of Magendie. Sometimes this is delayed in happening. And so if we see this, we may do a fetal MRI to look for other anomalies. We may suggest an amniocentesis to do a chromosomal microarray to look for any extra missing pieces of DNA. But if this appears to be isolated, the neurodevelopmental outcomes are uniformly excellent. And so we can be very reassuring to families when they find this Blake's pouch cyst, that it's not anything that they need to be worried about. With the caveat that with any pregnancy, there is a 3% risk of a baseline congenital anomaly. So it doesn't matter how normal your imaging is, you have a 3% risk of a cleft lip, cleft palate, or in a 2 to 3% risk of developmental delays. And the overwhelming majority of kids who have developmental delays have normal imaging. So you can't promise that there's not going to be an issue. So then the counseling is very straightforward when we're very certain about the outcome. And so, for example, this is an MRI. where we have a fetus that has a very thick cortex that has something called a cobblestone-less encephaly. They have severe hydrocephalus. They have Z-shaped kinking in the brainstem, and they have eye anomalies as well. And so this is a prenatally diagnosed case of something on the Walker-Warburg spectrum that uniformly has a very poor neurologic prognosis. But then the counseling becomes more challenging with other conditions. The data quality is very variable that's out there. There's heterogeneous patient populations. There's limited and incomplete developmental follow-up. And the best data comes when it's something that's considered isolated, that it's just the single anomaly that we're looking about. But the type of genetic testing that's been done based on when the literature was published, it might be a karyotype, it might have been a chromosomal microarray, and nowadays it's most likely going to be non-invasive prenatal testing to rule out things like trisomies. So we're going to talk about a range of conditions today just to give you a sense of the spectrum of things that we can diagnose, things that all come from that second trimester anatomy scan, something being flagged as abnormal. And we'll talk a little bit about what some of these mean for prognosis for the babies, and then how some of these can be intervened upon to improve outcome. So this is a case of ventriculomegaly that was diagnosed prenatally. So you can see the lateral ventricles are enlarged. And so typically, the ventricles are no larger than 10 millimeters at the level of the atria. And this is regardless of gestational age, so that makes it relatively easy. And so there have been different grouping strategies over time. Sometimes it's broken down in the literature to mild, moderate, and severe. Nowadays, it more seems to be just mild versus severe with an inflection point, and outcome seems to be about 15 millimeters. And there can be a tremendous range of causes. It can just be a normal variant. We can find that there's been a viral exposure, like cytomegalovirus is a common cause of mild ventriculomegaly. It can be that there's actually been atrophy of the brain causing enlargement of the ventricles, or it can be problems with CSF flow like obstruction, impaired absorption, or increased production, and then of course genetic causes. So in terms of a typical workup when ventriculomegaly is identified, typically there'll be serologies for things like CMV, and an amniocentesis will be offered to look for viral cultures, and then also to do some genetic testing. A fetal MRI will typically be offered, and about 10% of the time you'll be able to find additional anomalies that were not detected on the ultrasound. The yield is a little bit higher with an MRI if you just had a standard sonogram. Neurosonograms are actually quite sensitive and really very complementary in terms of MRI, in terms of what we can see. Okay, and so this is a very small flow chart, but just what I want to direct your attention to is in terms of prognosticating about ventriculomegaly, if we have mild ventriculomegaly, no other abnormalities in either the brain or the body, and we have normal genetic testing results, 92% of these kids will have normal neurologic outcomes. So overwhelmingly, we can be very reassuring to families that this mild ventriculomegaly is going to have a good outcome, but of course, 8% of the time, it does not. And so it's a whole other kettle of fish for more severe ventriculomegaly and when there are genetic anomalies, and we counsel based on those findings. Okay. And so this is our prenatally diagnosed ventriculomegaly. And so then these are her postnatal scans. And so she actually had just some connatal cysts, and developmentally she's done quite well. However, the family, even though they have this wonderful 5-year-old child who's doing great now, they still were very traumatized by their experience of prenatal counseling, being told that all these things could be terribly wrong with their child. And so we really need to be mindful of the family's experience of going through this process, being told that their child may have terrible issues, and balance that out between letting them know what might be, but also giving them hope for the future. Okay, so agenesis of the corpus callosum. This is one of the cool things that we can diagnose prenatally. So the corpus callosum being that big fiber bundle that connects the left and the right hemispheres, it's made up of 200 million axons, and it appeared evolutionarily very late. So in terms of random trivia, only placental mammals have a corpus callosum. So kangaroos and platypuses, they don't have them, and neither do reptiles or other animals. There are 4 major parts: the rostrum, genu, splenium, and corpus, all present in 17 weeks of gestation. And so we should be able to pick this up on our second trimester anatomy scans, especially because there'll be differences in the flow of the pericallosal artery that can be picked up if there's agenesis of the corpus callosum. However, it is commonly associated with other brain malformations, and so we'll routinely do a fetal MRI when we pick this up on ultrasound. So agenesis corpus callosum is not vanishingly rare. It's present in about 1 in 5,000 individuals, and it actually can be completely compatible with normal neurologic function. So we find this incidentally in autopsy series of people you had no clue had an absent corpus callosum. But when you look at the population of kids with neurodevelopmental disabilities, it's present in about 2 to 3%, so definitely enriched. And it can be disrupted because of genetic causes, because of infections, because of vascular insults or toxic exposures. And there are more than 200 syndromes that are reported in the OMIM database that can have the disorder of the corpus callosum as a feature. And so this is just an MRI showing us agenesis corpus callosum. So we're missing the fiber bundle. We see this, we call the colpocephalic configuration of the ventricles. And then this is diffusion tensor imaging, where different colors indicate the different direction of the fibers are running. And so we still have some crossing red fibers here at the anterior commissure. So just to be aware that even though the corpus callosum is absent, there is still some crosstalk between the left and the right hemispheres in most cases. Okay. And so this is just to illustrate that the corpus callosum develops over time. So when babies are first born, the corpus callosum is very thin and unmyelinated. And over time, it kind of plumps up and it gets more myelinated and distinct. And so, you know, sometimes it can be tricky to determine if a corpus callosum is present prenatally, and you may find out that it's actually hypoplastic. And so there's a lot of really cool neurobiology about the development of the corpus callosum, all the patterning that happens at the midline that guides axons across the midline, keeps them on the other hemisphere once they're there, and helps them find their targets. So there's a whole really neat body of literature there. And so when we look at the different syndromes that have been implicated in having corpus callosum agenesis as a feature, we try to divide them into terms of syndromes that might be involved in abnormal midline patterning or differences in axon guidance. But there are some syndromes that we just really don't know the genetic basis for. So for example, Aicardi syndrome is one that has been a very difficult nut to crack. It's clearly X-linked. We only see it in girls. Agenesis of the corpus callosum, typically colobomas, and chorioretinal lacunae in the eye, but we just haven't pinned down the genetic basis for Aicardi syndrome. We do know that if you do chromosomal microarrays for individuals with agenesis of the corpus callosum, there is enrichment in copy number variations in terms of small extra missing pieces, chunks of DNA. And so we typically would at least do a chromosomal microarray for agenesis of the corpus callosum. Okay, and so in terms of outcomes, so if we have complete agenesis in the corpus callosum, we have an otherwise normal brain fetal MRI, no other congenital anomalies, we have a normal chromosomal microarray. 75% of these kids do great. They have essentially normal neurodevelopmental outcomes. And in terms of the cohort of kids that I follow, this really has borne out over time. I'll typically follow them up until the age of 5 when they're starting kindergarten, because sometimes they have some subtle learning issues that become apparent and might send them for formal neuropsychological testing. But 3/4 of these kids, I don't see them after the age of 5. They just do great. However, we do know that 8% of them are going to have severe neurodevelopmental syndromes, and then about 15% of them are going to kind of fall into moderate disability. And so this is just a prenatal case of a little boy that I follow, his prenatal MRI, his postnatal MRI here. He also has some heterotopias, which we'll talk about in a minute. But so I followed him since before he was born. Now he's like 11 or 12, and he's actually on the spectrum and has technically normal intelligence and doing really well. He has a seizure disorder that's well managed. Okay. So in terms of babies that we know have agenesis of the corpus callosum, we typically do like to get a postnatal MRI just to get a more detailed, unless there's been a really good late gestation MRI. And so it's really relatively easy to do this for babies. We can do it with a feed-in swaddle, so they don't necessarily need anesthesia. And then we'll also call in the ophthalmologist to do a good exam because there is a risk of optic nerve hypoplasia when there are defects in the midline development. And so it's actually the clinical exam by the ophthalmologist is more sensitive than the MRI for screening for optic nerve hypoplasia. If optic nerve hypoplasia is present, about 60% of the time, kids will be at risk for pituitary anomalies. And so we'll do some screening endo labs, making sure that they don't have growth hormone and thyroid deficiencies and the like. And so then that leads us into the discussion about septo-optic dysplasia, because when you see a defect in the midline, the question is, could someone be on the spectrum of septo-optic dysplasia, which is actually a triad? So you may not have actually agenesis corpus callosum, but you can have absence of the septum pellucidum, that membrane that divides the two ventricles. And so if you have two of the three, either midline defects, optic nerve hypoplasia, and or pituitary abnormalities, then you meet the criteria for the triad of septo-optic dysplasia. And so it's actually rare to find a genetic cause for just straightforward septo-optic dysplasia. And it's actually proposed to be a vascular disruption sequence, because the affected areas all come from the same area. They're different tissues, but they're all supplied by the same artery developmentally. If you do genetic testing, we typically do a microarray, and there are a handful of genes that if you test for them account for about 1 to 2% of cases of septo-optic dysplasia, but usually don't get a satisfactory genetic diagnosis. Holoprosencephaly is actually, we actually can pick up on this frequently during just a routine first trimester scan, because we're looking at, this is failed or incomplete division of the forebrain into the two hemispheres. And this is actually happening in the 3rd or 4th week of gestation. So very, very early developmentally. And there's a continuum of severity that we need to keep in mind in terms of counseling families. It goes all the way from alobar to semi-lobar to lobar, and there's a middle interhemispheric variant. And we are also looking for associated midline anomalies that may be fused thalami. There could be problems with the corpus callosum. There can be problems with the olfactory bulbs and in the optic bulbs. And so this is just to show an example of alobar holoprosencephaly. As you can see, there's a lot of fluid there. A lot of these kids get hydrocephalus and need to be shunted for management. And then we look at the causes. There are clearly environmental causes. There's an association with uncontrolled maternal diabetes in terms of being more likely to have a holoprosencephaly, but then very commonly genetic, especially trisomy 13 is a common association that we'll be looking for. And then there are a number of genetic syndromes that are recognizable, things like Rubinstein-Taybi and Pallister-Hall, that kids have a syndromic appearance that can have associated HPA. But then there are a lot of non-syndromic causes, and these are the genes that are involved in that, like diencephalic patterning of the forebrain cleavage, all of these genes that control these processes. So the outcomes. So for alobar HPE, there's also the risk of children having facial anomalies, like a proboscis instead of a nose that can affect their respiratory tract. If kids have a normal face and can breathe, almost a third of them will live at least a year. Okay, sometimes people get inaccurately counseled about outcomes, and these babies will survive longer than anticipated. But if you go all the way to the lobar and middle interhemispheric variants, these kids, half of them will walk, many of them will have language, and can do surprisingly well. And so this is an example of what we call the middle interhemispheric variant. This is this child's prenatal imaging, and then their postnatal imaging. And this is a baby when we saw him back, he's about 2 right now and have his formal developmental testing, what we call a developmental quotient, which is what we do until kids get old enough to do IQ testing. Developmental quotient at about 60% for both his language and cognitive abilities. He does also have some issues with some spasticity. So lissencephaly. When we talk about lissencephaly, we're talking about issues with the migration of the neuronal cells going to the gray matter, and they become kind of disordered and jumbled, and the cortex will be smooth and it'll be thickened. And we're actually not very good at diagnosing lissencephaly prenatally, because when we're doing these anatomy scans at 17 to 21 weeks, the brain is still very simple. So unless there's really significant like microcephaly or small head size, we typically don't routinely diagnose this prenatally. So this particular case of a prenatal diagnosis of lissencephaly this was actually diagnosed because the baby had concern for a cardiac anomaly, and so they did an amniocentesis, which found that the baby had a small deletion in chromosome 17 that encompassed one of the lissencephaly genes, and so this baby had something called Miller-Dieker lissencephaly. And then this is just an example of a postnatal head ultrasound that was done. Okay. There's also something called microcephaly with simplified gyral pattern that we sometimes diagnose prenatally if there's impressive microcephaly associated with this. In contrast to lissencephaly, the genes involved in this control the proliferation of the progenitor cells. And so these cells will migrate properly, but there aren't enough of them. So the brains will be small. The wrinkles of the brain may be simplified. And so, so typically they'll have smallish heads at birth that become very impressively small over time. But these kids actually do surprisingly well. They can have just mild to moderate cognitive impairment. Interestingly, they tend to be short. The genes that are involved in this kind of phenotypic series have overlap with something called Seckel syndrome that is involved with short stature. They certainly can have a seizure disorder, but because their cells have migrated normally, they're not tend to be as severe as like you see with lissencephaly and tend to be relatively easy to control. And they may have some mild spasticity, but it typically doesn't need aggressive management. And these are just some of the genes that are involved with the microcephaly with simplified gyral pattern. Okay. And so then moving on to another migrational anomaly, periventricular nodular heterotopias. When we have those cells that are dividing at the ventricular zone, sometimes they don't migrate normally, and then they get these kind of stuck in the ventricular zone, and these are the nodular heterotopias. And isolated heterotopias are very, very common. And so if we see just a couple of heterotopias, we'll typically do a chromosomal microarray looking for copy number variations. If you have a very dense burden of heterotopias, there's a gene called filamin that's on the X chromosome. And so if it's a girl, it has this very dense burden. About half the time you'll find changes in filamin. And so this is just an example of someone who prenatally had these little scalloped appearance of the ventricular zone, and then her postnatal imaging that those nodules were present. However, there's a caveat with this, though, is that when we find what we think are nodular heterotopias prenatally, about only half the time are they present there postnatally. So this was a case where the radiologist was very convinced that we had some nodules here that were scalloping. And then even though there's some asymmetric ventriculomegaly that persists, those nodules are gone. So we just always need to keep in mind that sometimes these findings prenatally are not always found postnatally. And a similar thing happens with the condition of isolated cerebellar vermis hypoplasia. So that midline of the cerebellum in the posterior fossa. So this is just an example of a cerebellar vermis hypoplasia. And then the postnatal imaging, we actually see a very plump and healthy cerebellum. And so 85% of the time, these kids will actually have normal outcomes when we make this diagnosis of the vermis hypoplasia. However, in contrast, sometimes we pick up very serious conditions. So this is an example of the vermis hypoplasia that we saw prenatally. On the postnatal imaging, we actually found a characteristic molar tooth sign here in the midbrain, which is suggestive of something called Joubert syndrome. There are a number of genes that cause this appearance. And then when we look at diffusion tensor imaging, these are the superior cerebellar peduncles. They don't cross, and that's very typical of Joubert syndrome. So we're able to make a diagnosis after the baby was born with the postnatal imaging and then knew to test for Joubert. Dandy-Walker malformation. So the problem with ultrasounds in the screening is that a lot of stuff in the posterior fossa just gets labeled Dandy-Walker. And so we have to be very mindful of this, and this is really where fetal MRI is very helpful in delineating, sometimes it's really a Blake's pouch cyst, sometimes it's really isolated cerebellar vermis hypoplasia, but sometimes it's really a Dandy-Walker. So Dandy-Walker has this kind of cystic dilation and upward torquing of the cerebellum. And so it's associated with other anomalies a lot of the time. So we're always surveilling and looking for other anomalies. But in terms of counseling, if the child really does have a true Dandy-Walker, we talk with families that it can be associated with this low core tone or hypotonia, developmental delays, ataxia or incoordination relating to some cerebellar dysfunction, and also a risk for hydrocephalus. And so the literature suggests that about half of the kids who have Dandy-Walker will end up needing shunting for hydrocephalus. And about half the time, they will have a diagnosis of intellectual disability. So this is where we consult our colleagues in neurosurgery to help us with monitoring and assessing the need for intervention. And so the final anomaly that I will touch on right now is a really cool one called rhombencephalosynapsis. So it's actually a fusion of the cerebellar hemispheres that we sometimes run across. And so you can see that here, the fusion across. And it's very rare, but these kids, they have low tone, they have motor delays, they have abnormal eye movements and ataxia, and they have this really cool characteristic figure of 8 head shaking stereotypy. And we don't know why it is, but if you see a kid with that, you know to image their posterior fossa. And like Aicardi syndrome, we actually don't have any known genetic associations. There is one recognizable syndrome called Gomez-Lopez-Hernandez syndrome. These are kids who also have bitemporal alopecia and trigeminal neuralgia, but we don't know the genetic cause, but we see that, and that's the syndrome. Okay. So I'm going to turn my attention to 2 conditions where we actually do have some prenatal interventions that are very helpful. The first is twin-twin transfusion syndrome. So when we have monochorionic twins, they're sharing a placenta, which can have shared vascular connections, and there's a risk of imbalanced blood flow between the twins. And so you'll have one twin who's the donor who becomes hypovolemic, and the recipient becomes hypervolemic. And so this gets picked up on ultrasound because there will be discordant amniotic fluid volumes. And then there's a grading of severity from stage 1 to stage 5. And so this is just an MRI that shows 2 twins. And so this is the recipient twin. And here you can see that this twin actually has high drops. You can see the fluid in the scalp. And then you see this kind of change in the signal intensity of the cortex, that there's actually edema in the brain. And so, our colleagues in the Center for Fetal Therapy will actually do photoscopy and do laser ablation of the vascular connections between the twins to alleviate the situation. And so that can vastly improve outcomes. We know that both the donors and the recipients are at risk for injury, and that can be related to sequelae of the twin-twin transfusion, or of course, if you're a twin, you're at risk for being born preterm. So with some of these babies, we'll see cystic periventricular leukomalacia, we can see intraventricular hemorrhage, ventriculomegaly, we can see some atrophy, they're at risk for arterial stroke. But before they had the laser intervention, they would do this technique called amnioreduction. This laser has much, much better outcomes, and then the risk of neurodevelopmental impairment is much lower with this intervention. And then finally, I'll talk about myelomeningocele, which occurs in 1 in 3,000 live births. And the extent of the disability generally relates to the level of the defect. And then we're very aware of the risk of hindbrain herniation and what's called a Chiari-2 malformation associated with this. And so this is just a prenatal MRI of a baby who has a large defect here, and you can start to see the descent of the cerebellar tonsils. And so there's actually a role for prenatal surgical repair. And so there was a seminal trial called the MOMS trial, where they did actual surgery to repair the defect prenatally. And it actually had improved outcomes in terms of reducing the rate of needing a shunt and improved ambulation for the babies. And so actually now it's more standard of care to do this fetoscopically to avoid the need for the surgical intervention, the more invasive surgical intervention. And so this is a baby who underwent prenatal repair, and you can see significant improvement in the hindbrain there. Okay. So in summary, I hope I've impressed on you that there are a range of CNS anomalies that we can detect prenatally. When we find a baby who has a prenatally diagnosed CNS anomaly, they're going to need close developmental surveillance. So many are going to need pediatric subspecialists to help care for them in the future. And that we're always hoping that with this early diagnosis, it will lead to improved outcomes for the babies. Thank you.
Perinatologists and
It would be
OBs.
to come visit you.
So, but more seriously, with the kids with agenesis of the corpus callosum, it's a real difficulty. I mean, when one gives a lecture about it, it seems simple and that a lot have great outcome. But in a lot of studies, like what you were describing, these are really following for a kid who's about 5 years of age. And once they're really school age and then they reach high school, then that's when all the issues really present. And there's a significant percentage that you're not going to see early on.
Mm-hmm.
And parents we talk about percentages that have issues, but there's issues and there's issues, and it's a huge range of things. How do you deal with prenatal? You don't want to overwhelm with negative news that they're going to be living with, and does my child have this or not? But how do you deal with the issue of explaining that, some of these things can be subtle learning issues, some of them much more severe, and a lot of it really you won't know until someone is high school age or middle school, and not really something you're going to be able to comment on unless you did a $20,000 neuropsych evaluation on every child.
Those are great questions. So when we're doing the initial prenatal counseling, we're kind of more looking at like a 5-year window in terms of how we're going to monitor the child developmentally in terms of meeting their milestones, showing us the trajectory that they're on, and then when there's more school age, being able to do formal neuropsychological testing to really like pin down their IQ, if there are learning disabilities. And then I think you move to the next phase of you're doing great, but if issues arise, I'm here for you, check in with me. So it's kind of like a second part to the conversation. Get them to age 5. You have a better handle on their needs if they're going to be in special education versus, more just, doing well. And it's an ongoing relationship with the families. You can't like prepare them for the next 20 years when you're first meeting them when they're, 25 weeks gestation. Yeah, so you paint the range of outcomes, and these are difficult conversations that we have with families. It's like impossible. Like 3/4 of the time, your kids can be just fine. They may have some learning problems that manifest in school as demands increase. On the other hand, your child may not walk or may not talk, and so it makes it very impossible for families to like make informed decisions when you can't tell them. It's very, very broad, and so you just more kind of paint the different pathways. And you say, this is how we're going to monitor your child. These are the resources that are out there to help with your child. A lot of people don't understand like the role of like different therapies like PT and OT and speech, the role of early intervention services, and just, the family kind of having the sense when they come out of the prenatal consultation that there are supports out there. There are people who take care of kids who have these issues, and we are going to be there and part of their child's team.
In medicine, we don't hear it very often, and perhaps even more should be heard in the schools for people as a whole. But I would like you to comment about the condition we call it genetic and congenital, which is actually acquired during the pregnancy. One of them may be infection or drug. A small emboli or bacterial emboli may not bother mother, or one would not see it, but located in the brain develop lack of development of the brain, and it is called some kind of palsy when they are born. We studied, for example, effect of alcohol in rats. And the mothers after that was perfectly appear fine, the litter. But the litters were seriously disabled, not only physically, but then you study cerebellar Purkinje cells were markedly degenerated in the hypothalamus or Amon's horn in cells, while the mother was perfectly fine. So there are so many things, I think, impression-wise, that we call it congenital, or we call it hereditary, but may not be at that. What do you think about this thing? How do you?
Yeah, so that's a tremendous question, because, we're asking, what, sorry, okay. Yeah, because we're looking at cause, because we want to understand the cause so we can say, is there a risk of recurrence? Can we understand what the future holds? Is this going to be a static process? And so we grapple with those issues for sure. And one of the things that we do in our neurogenetics clinic is we evaluate a lot of kids who have a diagnosis of CP. So there are kids who will be referred from our CP center, say, they don't have a good history. They weren't born prematurely. They don't have any, MRI abnormalities consistent with like injury. And can you take a look and see if there's anything genetic? And so in a percentage of kids, we do find something genetic, but there are some kids who just don't have a good history of an injury, but they present with cerebral palsy. So I think that comes to there's, so much that's unknown about things that influence the developing brain. With the caveat that, there are kids that we evaluate and say, you know what, you were born prematurely, but we're still going to look because we think that you're more severely affected than we would expect with you being a 32-weeker. And it's very common for us to find that there's a second cause. So even if there was an in utero drug exposure, that doesn't rule out there being a genetic issue that we can find. Yeah.
Something kind of going on from what Moise said, but something that the program was looking to study that Eric Thompson had brought up is patients, babies with IVH and long-term outcome for them, meaning, we see a lot, you probably see them as well, the babies and then the parents, and they have questions about, will my child go to college and stuff like that. And so we were thinking about somehow studying that. It's difficult because you have to have 18, 20 years of follow-up and EPIC isn't around for that long. But what are your thoughts and how do people ask you those questions? Is it something that we should be studying as a program?
Yeah, so absolutely. So I do most of the prenatal consults with the caveat that one of my colleagues who's a vascular neurologist tends to do the consults when there are intraventricular hemorrhages and the like. So it's clearly like stroke-like issues. And so, the way these babies tend to end up in the NICU, and then there's a NICU developmental clinic at Kennedy Krieger next door, which is an affiliated institute for kids with neurodevelopmental disabilities. So we have a long history of the developmental pediatricians following these kids who had a prenatal or perinatal intraventricular hemorrhage or other kind of injury. So that data is there. We just need to have the manpower, the time, and resources to delve into it. But the information, the data is there in terms of long-term developmental follow-up of these kids that funneled through the NICU. 8% severe. Yeah. Anything else?
Thank you very much. That's fantastic. I think moving on, now I think we have a few moments, Bill, for you to, if you want, did you, Margaret and Bill, this is
I defer to Margaret as the face.
sure, sure. Great. It's or we can get the
Well, that's okay. Well, I'll just hold this in. Before you walk away, Dr. Yamini, I just wanted to make just acknowledge you and what you've done. We had a group together last night of speakers, and we had a chance to talk a little bit about what you've done. This is what we're doing is really David Frim's vision that we bought into. That as patients, as Margaret is a long-term patient of Dr. Frim, and over the years we got to talk, and he expressed his vision of what he wanted to do when he stopped operating, and we bought into that as a family, and with all that he did for Margaret over the years. We bought that vision, and I remember him looking at me and he goes, well, where did you come from? How did this happen? I never saw this coming. And I said, well, that's the kind of the way it happens once in a while. So we're extending that legacy. Unfortunately, he left us too early, but he's still here, and we're living that. And Dr. Yamini has stepped in and done just a unbelievable job in transitioning that legacy, that vision, and ensuring that as we see opportunities to grow and pivot, which we have, he's leading that charge. So thank you very much, and you're doing an outstanding job. Much appreciated. And now I'll turn it over to the face and the center point of this of everything we do, and that's Margaret.
All right. Well, I'll be brief, but I just want to thank everybody who came today. And our hope is just that, every year we've done this, it's just to kind of bring together, brilliant minds, and everybody who comes has knowledge to share, and we all learn from each other, and we learn a little bit more about all of these conditions, and by bringing people together, we kind of share ideas, and it spreads more information and gets more out there, and I think every little bit makes a difference, and that's really what we wanted to do. That was our goal, and I see every year we've had great success, so I hope everyone enjoys it today.
Very good. Very good.
Hi, I'm Renelle. I'm Margaret's mother. So I'm not going to go on about the foundation, but I would like to share an anecdote of Dr. Frim. So we knew him for many years. As Margaret started, we knew what, 15 with him, or was it even younger? And actually, we called him because of the video Margaret saw online. He did the video where they took off the back of the skull and put it back on him, cut it up and put it back on the mesh in the back. And so she's like, we got to call this guy. Because right then we had left Children's Memorial because they said there was no more they could do for us. So on Margaret's recommendation, we called Dr. Frim. He's like, well, take a look at her, And anyway, so over the years, we came very close to him, and he trusted Margaret. He'd send the residents up to talk to her without going with them. He's like, just ask Margaret, she'll tell you what she needs. And so, but if you're close with Dr. Frim, you know how straight-laced he was. He was also very humble. So when I went to his funeral, I learned all this stuff that I didn't know. All his athletic achievements, all his religious achievements, that he was a lecturer in the Jewish tradition. And I'm like, why did he find the time for all this stuff? Because I know he didn't leave this hospital till at least 8 at night. And he was there first thing in the morning. I'm thinking, I don't know. But I was so impressed. I was so glad to know that he was well-rounded. Because he didn't really talk about himself. I mean, he did mention his sons, if prodded. But other than that, he was very humble, very kept to himself. And so when we started the foundation, it was his vision, it was his idea. And so we just took it on with him and began this. And I was waiting for something from him like a, I'm like, so this went on for a couple of board meetings. And finally I said, Dr. Frim, well, I didn't get my, you are happy with this, aren't you? Yes, yeah. Okay, can I see? Yes. Can I see? Got it, man. But no, he's just not him, unfortunately. But for all the good he did, we will miss him. And again, thanks, Dr. Yamini. All right, and with that, I'll turn it.
And not much more to be said. I think I would like to, again, beyond Dr. Yamini, he doesn't do this by himself. And the team, Julie, and you heard from Ashley and Jess. It's just, everybody makes this work, and we can't say enough how much we appreciate and everything that is done by the team here at EU Chicago. So thank you on behalf of the family and on behalf of the foundation. And the last thank you I'd like to do is give to my board. We put together a terrific board of directors. We have one of our directors here today, Carolyn Winus. Carolyn and I have had a career together outside of the foundation, and she's here to ensure that Margaret has a voice, because otherwise it'd be a bunch of old guys sitting around a table thinking we're smarter than we really are. And she's really helping us. And in addition to Carolyn, we've got two great doctors, Dr. Kazin and Dr. Zindrick on the board. Both are wonderful advocates for Margaret and for the program. And then Pat Byrne and Greg Mulloff are also affiliated with us, and they just do a wonderful job. So thank you very much. Thank you, everybody, for attending. And to the presenters, thank you so much for taking your time on a holiday weekend, by the way, to join us and bring so much more value to what we're doing, because you do. Thank you.
Thanks very much, Bill, Raynell, Margaret. So I think we have one more talk before lunch. Just let Margaret settle in. No, take your time. Canine Companions, Fido, 5-0.
Okay, all right, you know what? It's just revive it down.
So, the program, it has been going on for several years. We have a consortium where we get information data from lots of different patients. And we're in the 2020s. And so I thought that I think it was probably the board and Bill that you'd come up with talking about having us look at things maybe from an AI perspective. I mean, we want to be as much on the cutting edge as possible. And when you have lots of big data, it's hard to get big data with these kind of rare conditions and stuff. But when you have a significant amount of data, clearly, the way to look at it is AI. I would tell you that I know very little about it, but Dr. Galampur is an expert in AI, and I thought this would be a perfect opportunity to show it to people like me who are pretty much have no knowledge about it, and maybe some of the others have no knowledge, but maybe some of you, especially the younger ones, may know a lot about that. So Saif is one of our researchers. He was PhD in engineering, fluid mechanics and stuff, but really an expert in many things engineering related, and AI is one of them. And when even discussions between students or all the way up to the board of trustees of the hospital are talking about AI. They have people, experts come in and talk, and it's clearly a very important thing. But there's a lot of misinformation out there as well, I'm sure. But I think Saif is going to give us a kind of a general introduction on it and a discussion about how it might be incorporated into the program.
Thank you very much. Thank you very much. It's on. I don't know. It's on. Thank you very much for your attending. Today, we want to talk about applications of AI, artificial intelligence, in the context of congenital CNS anomalies. I'm Saif Galampur. My master and PhD was in medical engineering. I have no disclosure. people are curious to know what will happen. What will happen in the future? If you look at high-grossing movies, high-selling books, majority of them are talking about the future or the prediction of the future. And also magicians made a lot of money based on this need. AI is designed to answer this question, the prediction of the future. First, we will talk about a little bit about the introduction of AI, history, types, platforms. Second, AI-based prediction in diagnosis and treatment. Then key applications of AI, especially for congenital CNS anomalies, and finally, some limitations. First AI paper was published in 1950, Alan Turing. And this was the first AI conference. Everybody says this was the birth of AI. And Alan Turing and McCarthy, they were the primary developers. And maybe we can say nowadays, Sam Altman, ChatGPT, is one of the main developers. The history of AIM. AIM means AI in medicine. First AIM paper was related to EEG. And the birth of AIM was just 49 years ago. The primary developer for 2 decades was Stanford under SUMX program. And nowadays it's so hard to say who is the developer because a lot of universities are working in this field. We can say the contribution of Stanford, MIT, Mayo Clinic, Harvard, and Johns Hopkins is more than other ones. In industry, AI in medicine has the 4th place. But the interesting note is its growth rate is higher than other aspects of AI subsections. For example, AI in tech, the first one, its market cap is bigger than AI in medicine. But the growth rate of medicine is higher than tech. Many people believe the future of AI is AI in medicine. I don't know. AI means a machine that can learn a specific task from us and repeat it. But it can improve itself. It's important. AI has 2 main types. First one is artificial narrow intelligence. Second one is generative AI. Artificial narrow intelligence means machine can learn and repeat, like self-driving cars. First, machine learns what the brake is, what the gas is, what the traffic light is, and something like this, then it can drive your car. For example, when it wants to parallel park, maybe those 2 cars that it wants to park your car between have different shapes, different sizes, or maybe they park poorly, but in all conditions, it can park your car between them and maybe even better than you. In diagnostic, for example, first machine learns what the MRI image of a healthy subject is, what the MRI image of a hydrocephalus patient is. For example, using 500 MRI images of different healthy subjects, 500 MRI images of different hydrocephalus patient. We will talk about the process in the next slides. But finally, when we have a new case, it can differentiate hydrocephalus from healthy subjects. But in generative AI, machine learn a specific task, but it can generate new data, not only learning and repeating like ANI. Here, machine learns, but it can create original data, like ChatGPT, Gemini, Copilot. For example, when I asked ChatGPT, show me a birthday party on the moon, ChatGPT generates this picture. Machine didn't learn this specific picture, but it knew what the birthday party is, what the moon is, you know, and based on this information, it creates original data. This part of AI, it's less developed in the context of medical science, you know, ChatGPT or something like this. I don't want to say it's not developed, it's less developed. There are a lot of startups which are working in this field, but nowadays we can say only we can talk about ANI in the context of congenital CNS anomalies. But from last year, the growth rate of generative AI in medicine was higher than ANI. So maybe this will be the future, but today we only want to talk about ANI in congenital CNS anomaly. ANI in one word is learning repeating, that's all. AI has two subfields, machine learning and deep learning. I'll talk about the definition of them in the next slides, but for implementing these subfields, we need some libraries. You can see some names. And finally, we need a platform to manage all of these relationships. Google, Microsoft, and Amazon are the most famous platforms. And here in MHFE, we use Google platform and we use Python as a programming code for executing all of these procedures. What's machine learning? For example, we want to predict shunt failure, and we want to know what should we do. Machine learning. First, we have to split our data set under three subsections: training, validation, test. And in training step, machine tries to learn the relationship between variables and outcomes. For example, we have a database that includes many patients. Machine tries to find the relationship between changes in age of different patients, type of different patients, etiology of different patients, and other variables with changes in shunt failure status using some mathematical algorithm. In the second step, in the validation step, machine optimizes the settings of this algorithm because we have some settings and parameters that should be optimized. After passing these two steps, machine claims, now I can predict. But the point is, we should check the correctness of this prediction. So from the beginning, we kept 15% of our patients randomly for this step, for checking the correctness of our prediction. External validation is similar to test, only the patients are from other hospitals. We have to repeat all of these three steps for approximately 20 machine learning algorithms, and finally, we should find the best algorithm based on accuracy. Okay, for example, for a project, we passed all of these steps. Now, how can we use this data? How can we use these results? First one, classification. For example, now we have a new hydrocephalus patient. We know the age, type, etiology, and other things. For example, our neurosurgeon wants to use a strata valve and wants to set the performance level on 1. And for example, our neurosurgeon wants to use catheter, occipital catheter, and other things, you know. Now we want to know what will be the shunt failure status. For this specific patient, our results show the status will be shunt non-failure. But if we change these characteristics, the result will be changed. But there is a point here. Look, the accuracy is only 76%. This means we have 24% error. Is significant. For practical, maybe for publishing paper it's good, but for practical, using 24% error is significant. If we have a larger database, we can increase the accuracy. So the second question that machine learning can answer, we have another patient. We have, for example, this was the age and type, etiology, and other characteristics. Now we have another question. After shunt surgery, what is the optimal shunt valve pressure setting to minimize the likelihood of shunt failure. We know shunt valve pressure setting is not everything to minimize the likelihood of shunt failure, but this is a variable and this has an impact. How can we optimize it? This is just an example. For this patient, the results show CSF drainage pressure should be between 1 to 2.5 centimeters of water. This means we can use a Strada valve, a programmable valve Strada, and we can set valve performance level on 0.5. 0.5 means this range. If we change the patient characteristics, the result will be changed, but we have a still 24% error, and maybe it's not good for practical using. The third question, identifying the important variable. Look, here we have a lot of variables, age, type, and other ones. Which one is more important? Which one has less importance? So in this step, SHAP is a game theory-based method. SHAP says, for example, we have some basketball players and we want to get a point. After getting a point, SHAP determines the contribution and importance of each variable in getting that specific point. Players are similar to variables like age, etiology, type of hydrocephalus, and other ones, and getting a point is similar to prediction of shunt failure. And it will determine the contribution and importance and sensitivity of each variables for prediction of shunt failure. Actually, for answering the third question, important variables, traditional statistical analysis, multivariate logistic regression analysis can also answer this question another way, based on p-value, based on odd ratio, and other metrics. Yeah, it's a really good method. You know, it's faster, it's simpler. We can use it for answering this question. This logic is different. It works based on significant, not importance. There are some requirements. For example, this is a parametric method. Maybe there is a relationship between these variables and prediction of shunt failure, but this relationship is not parametric. Maybe it's a non-parametric. In this case, multivariate logistic regression is not designed for these types of questions. If you have a project that can meet these requirements, I suggest you to use this one because it's simpler, faster. Let me look at last published papers in JNSPs and see the applications of machine learning. In this paper from Pennsylvania, they predicted tether cord development after surgery, and using SHAP analyses, they measured the importance of each variable. In this paper, they predicted the readmission after surgery in CM1s, and using SHAP analyses, they determined the importance of each variable. I don't want to get into the details of these projects. I just want to show you some examples about using machine learning and SHAP analyses in recent papers. Let me look at one of our projects in MHFP about SHAP. We measured 30 variables and this line, and ratios. You can see the parameters, you know, between two groups of cases, hydrocephalus patients and healthy subjects using manual image processing. Now, based on machine learning and SHAP analysis, we want to answer this question. What is the key neuroimaging biomarker for diagnosis hydrocephalus? The results showed the most important parameter is ventricular volume. Approximately is obvious, everybody knows, but measurement of ventricular volume is not easy for clinicians because they have to apply segmentation, image reconstruction process. It's time consuming. But interestingly, the results showed Huckman index, look, its importance is approximately similar to ventricular volume. This means its diagnostic importance is approximately similar to ventricular volume, but it's a sum of two linear parameters, and we can measure it on POX easily. And also you can see the importance of bioquadrat index and other ones. We can also talk about the how each parameter impacts on prediction and other details. Second one is deep learning. As I said, machine learning has two subfields. AI has two subfields, machine learning and deep learning. What's deep learning? Why should we, how we can use it? Look, the procedures are totally similar to machine learning. Training, validation, test, external, everything is the same, except for this step. For training a step, it used some hidden layers. Look, layer 1, layer 2, layer 3. This is just an example. In each layer, we have a mathematical algorithm. This means deep learning is the combination of, for example, 3 machine learning, or the combination of 5 machine learning if we have 5 layers. And you can see the networks between these layers is a little bit complicated, yeah? That's why we say deep learning is similar to a black box, because we know what the input is, we know what the output is, but interpretation of the relationship and these networks is really complex. Why should we use this method? Because machine learning cannot always predict. Sometimes we have to use deep learning when, for example, our input data are images or voices, voice in patient with speech disorders. Let me look at some examples, some applications of deep learning. First one, automatic diagnosis. You know, there are some papers, and you can see hydrocephalus, automatic diagnosis of IVH, CM1 from JAMA, Nature Medicine, and other ones. For example, hydrocephalus, how machine can diagnose, how machine can differentiate hydrocephalus from healthy subjects. You know, when we have 2 images, the logic is automatic measurement of volume. Machine automatically measure the volume of brain in these 2 images, volume of ventricular system in these 2 images, volume of subarachnoid space, and other things, other substructures. And eventually, using the comparison between these volumes, it can predict, it can diagnose. And also other methods like edge detection. These work based on color, darker color, lighter color, and also other parameters. The second application of deep learning is improving the quality of neuroimages. For example, when we have a CTA from patient with aneurysm, and we want to distinguish between aneurysm and infundibulum, in this paper, in these 2 papers, they used AI, they used deep learning to improve the quality of image for a better diagnosis. And last one is computer vision. Computer vision means, for example, we have 2 images before and after surgery. It can, using comparison between the volumes, it can evaluate the treatment, the surgery effectiveness quantitatively. But sometimes our input data is not image, like this paper in Nature. They wanted to classify tumor types, congenital and non-congenital. Their input data was not images, but because of the complexities of this disorder, because of the complexities of this database, they used deep learning. We talked about the applications of AI, but there are some limitations. AI, similar to other methods, has some limitations. First one, data, big data. If we have a bigger database, consequently, we will have a higher accuracy. And if we have a smaller database, we will have a lower accuracy. But the question is, what does big data mean? How many patients? Thousands? Hundreds? Answering this question is really difficult because there are a lot of variables for answering this question. Let me talk about some examples to give you an overview about the population. For example, in this, for example, in this paper, you know, in this paper, they had only, I'm sorry, let me find the pointer. Yeah, this one. In this paper, they had only 73 patients from Pennsylvania. And the accuracy was 82%. This was a retrospective study, 73 patients. But Why? Because majority of these variables are numerical. It's very important. When you have a lot of numerical parameters, you can have higher accuracy. But for example, in this, for example, in this study, we had 283 patients, but accuracy is only 76. Why? Because except for age, all of them are categorical parameter. It's very important. Another limitation of AI is related to some specific applications of AI in medical science, like survival analysis. Survival analysis is important in medical science, but these codes are not developed completely. Another one is imbalanced data set. In many of medical data sets, our data set is imbalanced. The population of patients with, for example, shunt failure and non-failure are not the same. There are a lot of difficulties in this paper. I talked about some of these methods. And platform, if your input data is image, you need a higher RAM, you need a higher hard capacity and a better TPU, so you should pay more. And finally, the future limitations. You know, if a neurosurgeon wants to use AI results, AI should be responsible about the results. Because, for example, if there is a medical error, what is the role of AI in this case? So maybe some laws and policies should be issued or corrected for using AI results practically, like self-driving cars. Nowadays, in some states like California, they started to issue some laws and policies about self-driving car. If you have an accident with a self-driving car, who should be responsible? I paid for it, I should be responsible? Or the AI developer of these car, who? And we have the similar problems here. I want to thank Margaret Hackett Family Program as a funder of all of our projects and papers, Professor Bakiamini, Julie Fernandez, and my team members. Thank you very much for your attention.